A very good afternoon, ladies and gentlemen. I hope everyone is doing well and looking forward to the event. I'm Sneha Singh, and I'm really excited to host you for Digital Health Africa Summit organized by BII World. Uncertainty breeds innovation, and these are among the most uncertain times in healthcare industry. COVID has sparked a big bang in this industry. Healthcare was already evolving in its own pace and in digital transformation. However, the pandemic has accelerated its tempo and proved that the industry is capable of adaptation, agility, and innovation. The pandemic is rapidly driving organizational change and prompting healthcare leaders to consider future needs and opportunities. As the journey from crisis to recovery gets underway, the enablement of the future value based healthcare ecosystem must be the end goal, promising prevention of disease, increase in efficiency while lowering the cost, and most importantly, improve the patient care. Setting this as the backdrop, we are delighted to host some of the great minds in the healthcare fraternity to inspire the imagination that will change the future of healthcare. With the global disruption across every aspect of healthcare, explore how technology has enabled the industry to navigate this new normal and drive fundamental shift in approach to strategy, data, and people. This conference promises to offer bird's eye view of the current market situation and the latest technology innovation and strategies for propelling your organization to meet the unique challenges of this unprecedented times. I would like to thank all our speakers and panel members for taking time out from the busy schedule and are here with us to share their insights via interesting presentations and some interactive panel discussions. We also feel proud to have Elsewhere as our associate sponsor, Walter Polar as networking partner, and South Africa Health Informatics Association as supporting association. Before we start the event, here are a few tips for the delightful and seamless experience. On your home tab, please click on schedule to know the session of the day. Press on the speaker tab to know more about them. Click on the speaker profile to chat with them. Go to the booth tab to meet a sponsor and check out their interesting product that they have to offer us. Click on the lounge button to post and read live feeds and connect and network with other attendees with the tab present next to it. When the session is live, go to the schedule and click on join now to view ongoing speaker session. During the live session, you can share your thoughts on the chat section present below your video screen. Please post your question on question tab present next to the chat section. Our speakers would really appreciate and welcome your questions, so please feel free to ask them. Please note, anything relating to the conference administration, you are requested to address your queries to my team from BII World who are present there. Thank you so much. Now we head to a very interesting panel session that is called the Mythbuster. Technology is expensive, but it is no brainer that it is a necessity of tomorrow. It is moderated by Althea Davis. She is a country ambassador, UAE, and a board member to International Society of Chief Data Officer, and she's a CEO and CDO of Turnkey Solutions. And we have our expert panel members over here. We have Dr. Koni Law, Executive Director of Gateway Health Institute. We have Nara Krish, board member of InfoStart Software Services, and he's also an angel investor across all healthcare domain. We have Dr. Augusta Donning, Head of Africa Business, LenMed Health. We have Laura Zwok, Commercial Director, Advanced Clinical Decision Support from Elsewhere. We have Dr. Rafal, Assistant Director from Lagos State Ministry of Health. Over to you, panel members. You can switch on your camera and can start the panel discussion.
Okay. Hello. Good afternoon, everybody, and welcome. Greetings from Abu Dhabi. My name is Althea Davis, and I am the moderator of this highly exciting topic. We are first going to start and just do a very brief introduction for every member, and then we're going to get to the questions. So I'd like to ask, first of all, I'll do a quick introduction for myself. My name, like I said, is Althea Davis. I'm a 6-time Chief Data Officer working mostly in banking, big brands, and the European Union. And I would like to introduce the rest of my panel members. Dr. Augusta Doring, can you please introduce yourself briefly?
Thank you so much, Althea, and a warm welcome to everybody from Durban, South Africa, and that is a view of our beautiful city behind me. I'm the head of Africa Business for LendMed Health, which is the fourth largest health group in South Africa. We also have investments outside of South Africa, and we are looking at expanding onto the continent of Africa, specifically in the digital space. So thank you all, and I wish you all a pleasant afternoon.
Okay, and then we'll go on to Dr. Kuni Lau. Can you please present yourself? Dr. Kuni, can you hear me? Okay, maybe if you don't hear me, we'll move on to Laura Swak. Laura, if you introduce yourself.
Yes, thank you. Also, welcome from my side. My name is Laura Zweig. I'm the Commercial Director for Advanced Clinical Decision Support in Elsevier. Elsevier is one of the leading scientific publishers in the world and information analytics company. I'm responsible for advanced clinical decision support solutions in oncology and primary care in the markets of Middle East, Africa, Latin America, and Asia Pacific. And I'm very pleased to be here today.
Thank you very much, Laura. And where are you joining us from?
Yeah, I'm joining from Munich in Germany.
München, grüß dich. and then we go to Nara. Nara, please introduce yourself.
Thank you. Myself, Nara Krish. I'm from Kenya. I've been an investor in the healthcare platform recently. I have experience over 25 years in healthcare, hospitality, and retail. So having had this brief introduction, I've also had a lot of experience on mergers and acquisitions. Just recently, I did a transaction of raising a capital of $115 million, which is considered the highest outside South Africa in the African context. So that's one of the latest achievement. And then lately, I've been awarded with the Global CFO Award.
Wow, amazing. I've got some really interesting questions for you. Thank you very much, Nara. And then we'll go back, I think, to Dr. Kuni Lau. Are you there? I don't know.
Yes.
You are there, great. Hello, hi, welcome.
I'm good,
Please
thank you.
Introduce yourself.
Yeah, I'm Dr. Kuni Lau, Executive Director of Gateway Health Institute. I'm joining you from Limpopo province in South Africa today. We are a small NGO working mostly in the digital technology space, and we aim for our beneficiaries to be mostly young people. Thank you.
Great. Thank you so much for joining us. And then we're going to go on to Dr. Ralph. I hope I'm not chopping up your last name. Are you there, Dr. Ralph Akanja? I don't know if he's in yet. We'll catch up with him in a minute as soon as he gets in. I think I've covered everybody. So what we're going to do is get really quickly started with the questions. Dr. Augusta, are you there?
I am, thank you.
Hi, Dr. Augusta, we're going to start off with you. So, we're going to make it a really hard act to follow for everybody else, right? Okay, so with rapid consolidation of healthcare institutions, the estate globally, it's on a rise that, it's not seeming to change. Do you consider data assets as a material corporate asset in the due diligence process as you acquire the different medical facilities? What do you think about this? How is it perceived as part of your regular process, your strategic process, and your valuation of hospitals and healthcare facilities?
Thank you. Yeah, that's a great question, and it's great to be put on the spot because I am with such an esteemed group of panelists. So as I mentioned in my introduction, we are looking at expanding into Africa, and we do already have a number of facilities in Africa. But during the due diligence process, the assessment or the evaluation of the future companies' digital assets are absolutely critical. And I'll tell you why I say that. we are doing this actively because the cost of setting up infrastructure within the healthcare space is not cheap. So if somebody has already taken steps to prepare their business in that way, that certainly augurs well for the transaction. In addition to that, we obviously look at the things that support digital infrastructure, like the hardware, like the software that has already been purchased, and then we look at how the systems are integrated. Does this particular facility or this group of hospitals already have a strategy, and does the information from one department, for example, the reception counter at a hospital, is that talking to what is being submitted to the funder? Is the patient made aware of this? How does this impact on the entire customer experience? And customer experience for us as LandMed is a key factor in deciding whether a hospital can be made to be something more relevant to the community, or whether the hospital is perhaps already at that level where the customer experience is significant. So data really tells you who the customer is, and in turn, how is or was the customer best served by this hospital. So it can translate into something as complex as the patient outcome. If the hospital is already using an integrated data set to inform outcomes and to inform the team approach within the hospital, it tells you a lot about that particular institution and the value that they're adding in their community. I'm just going to quickly talk briefly about accreditation. So a data set in a hospital, or an integrated data set, can be extremely significant in accruing accreditation for that facility. And you'll know, being in Abu Dhabi, that Joint Commission International is the gold standard of accreditation. And if you look at any one of their processes, as well as some of the other accreditation processes, data and integrated data is the backbone of that. Thanks so much, Althea.
Yes, thank you so much. Do we have time for a second question quickly, or should we move on? A second question for you, Dr. Augusta?
Sure, absolutely, if time permits.
So I just want to give you the chance. So does data and digital assets play a role on determining the optimal asset portfolio? I mean, for your company, business portfolio. Is it taken into consideration as the market shifts towards care delivered away from the facility, the actual hospital or the medical facility, and with the focus on a more digital infrastructure and patient data harmonization, as well as operational efficiency? So where does it fare?
Yes,
for you?
So in the healthcare space, cost efficiency can determine access, and we see that especially on the African continent. So let's take a simple example of a patient having to redo radiology and pathology. If you have an integrated health record, which comes from a solid platform within a hospital or within a clinic, or even within the structure of a couple of general practitioners within a community, linked up to a pharmacy, linked up to an X-ray department, to put it in really basic terms, you are immediately creating value add and reducing the cost of healthcare both to the patient, and if the patient has funding, has insurance, to that provider as well, because you're cutting out duplication immediately in that system. So to your point, absolutely relevant. And of course, just to talk from a customer perspective as well, if all of these things are in place and are adding value, the patient experience is so much better, because patients are not duplicating their effort in seeking these key measurables that actually determine their diagnosis, and then finally the outcome of their treatment. Thanks.
Yes, thank you so much for that. That is so relevant. I mean, it's really about, getting the best care, and also the people in the process delivering that care, they need to be enabled to be able to do that. So thank you very much for those very expressive, informative answers. Now we move on to the next victim. Sorry, we're going to go to another doctor, Kuni Lau. I hope I'm pronouncing your name correctly. Dr. Kuni, I have two questions for you. The first one is there are so many areas of people's well-being that have grasped media's attention during the COVID pandemic. That everybody's talking in many different countries about the state of the health of the mental state of people. And the center stage of this is a cross-section between youth, mental health, or what some would call a generation under siege. At least where I'm from in the Netherlands, that's what we talk about. Raising rates of bullying, depression, and suicide are raising, and also things like raising domestic violence that we've heard of that's been outrageous against women and children during the pandemic. All of these kind of cofactors are going on. So in your opinion, in your option, is it true that potentially data and digital means can make a difference in people's day-to-day lives, especially in crisis moments? And that this is not just about sound bites, but actually saving people's lives and giving people hope and also access. So what do you think about that as a really frontline NGO?
Althea, I think what you are saying is true. COVID pandemic has definitely highlighted a lot of hidden issues, especially in Africa, where there is a big digital divide between the haves and have-nots. And when I'm saying the haves and have-nots, I'm talking about those that have access to internet, those that have access to smart devices. It's easy for us to say, oh, let's develop an app. We're going to address your mental health with an app. But does it work in Africa? Is the digital divide so big, the youth unemployment so high, the insecurities, the socioeconomic circumstances? Does it allow for young people to have access to data even, or money for a smartphone? Yes, it's data and internet can be harnessed in a good way to definitely address mental health issues, gender-based violence, which we also saw peaked during the COVID pandemic. It almost doubled in some circumstances. So yes, I think if we want to use digital and if we want to use data, we should definitely first use that technology and focus on the lived experiences of those people, so that we can have evidence-based development of digital technology. And then the immediate focus should also be on reducing the barriers, such as the digital divide, such as the lack of access to services. We all know in Africa that the mental health especially has been a neglected area, especially among young people, because in primary healthcare, it's just a fact that the primary healthcare service providers like nurses don't have the time to do mental health assessments, don't have the time to, they are pushed and overworked and overburdened, and sometimes I want to venture and say underpaid. So yes, we can use technology to a good sense, and in that sense, Gateway at the moment is working on using a basic technology to do it for developing a mental health screening tool based on the American Psychiatric Association's tool that they're using. And that service will be free, and people will be, well, if I say free, it's not solidly free. We pay for actions, yes. But anyway, yes, we're busy developing a screening tool that will give primary healthcare providers a mental health scorecard, which they can view when the patient comes in, and not have to spend time go through a series of questions to determine your mental health status.
Got you.
So yeah, that is how we can use data and technology. But in Africa, really, we have to focus on using low-cost basic technologies and not aim for the big mobile apps that we know people can't have.
Right. So this is really about low tech and data. Yes.
Exactly.
Combination. Okay. Thank you very much for your very highly interesting answer. I have a second question. So in the media, there's a lot of hype about digitalization, big data, technology, and AI, obviously. These things can do anything according to mass media. These things can remedy the world of all ills. However, when it comes to complex, real world, and deep-seated cultural behavior driven by social unrest, which have existed for generations, how can these modern means, or data in general, be put to work for social good? How can these means make a real difference in a child's life or a social group? How does your organization adapt these means to change lives? And how do you feel that you and your collaborative partners address this disparity?
That's quite a question.
I know. I'm sorry, but I wanted to give you some meat to work with.
I think the first images we had of how technology can be involved in social change is the Arab Spring that we experienced a few years ago, right? When people organizing and on social media. So that showed how people can use technology to actually organize as communities or as populations, for that matter. What I also know is that yes, we can talk about the social good of digital technology, but we must also always guard against the harm, because governments, especially authoritarian governments like we're seeing at the moment, are very quick to down on the use of technology, social media, all kinds of digital, when they want to sort of repress their populations. So another factor that before I get to the good, I also want to say that we always need to guarantee safety and the privacy of our users. In South Africa, the POPI Act came into being from 1 July. Have to comply with data protection and all that. I still have to go for training myself, apparently, do everything. But I think COVID has highlighted again social unrest as well. I remember clearly in the beginning of the pandemic in South Africa, we had food riots because of the hard lockdowns and people's food insecurity and social insecurity, and unemployment suddenly shot up. There was a lot of social unrest. What we realized as an organization, together with a few partners, was that people needed accurate information. There's such a lot of misinformation going on. Again, now during the vaccination drives, we need to counter the misinformation with accurate information. And what we did as an organization with a few partners, we developed an information portal, again on USSD, free of charge user, where we provided accurate information about what is lockdown, what is social distancing, why. You need to give the why and not the information as well. And that's really successful. In the same breath, on that same platform, we developed a functionality where people could report human rights abuses. We know very well that it's every pandemic and every lockdown and every restriction government puts on you is an opportunity for people in power to abuse that power, right? And people need to be able to report domestic abuse, report human rights abuses, ask for food parcels. We are quick to say, wash your hands, but what if there's no water? We allowed people to report water shortages. So through proper information dissemination, we can make a huge difference. And what we should also always remember is diversity and inclusion. We are very quick to exclude certain groups or certain ethnicities or certain genders or gender identities from certain things. And if we develop technology, we must always make sure that we include that, whether it's a young person or an older person. We need to make sure that we
ethical.
And it's ethical technology, right? So what we further did is that we developed eventually, when the food security issue in South Africa became huge, we developed a platform on USSD again called Smart Voucher, where people could apply for a food voucher through their mobile phone, have it approved, get a voucher number, and they could redeem that voucher at any of the participating retailers to make sure that their children had food, because we as an organization focus especially on food security for children under 5, because stunting is an issue in Africa. So we focus on families with kids under 5, families with chronic conditions such as HIV, and we allow them to apply for vouchers, and then we send them a voucher according to the number of family members, etc. So I think we made a real difference for kids in terms of food security. Thank you.
Okay, thank you so much. I know we're moving a little bit too slow, so we're going to have to pick up the pace, but that was highly relevant and so important that people who can't do for themselves, that those of us that have actually do something for them. So thank you very much, Dr. Cooney. And now I'm going to move right along to Laura Zwack in Germany, in Munich. Laura, are you there?
I'm there.
Okay, thank you, Laura. Laura, my first question to you is about poverty and health access has always been a challenge for people globally. In your work with outreach to isolated communities, how does your organization see that digital and data make lives better? And I know you have an idea of what I'm speaking about, so I'm just going to give the floor to you and be quiet.
I'd very much like to share an example of how data can make a difference for specific groups. In that case, for pregnant women and children under 5 years. And so we have just concluded, Elsevier has just concluded a study with pregnant women and children under 5 years in remote rural areas in India. And we demonstrated that a clinical decision support solution can make a difference here. So I think we all know in India, the mortality rate of mothers and children under 5 is still unacceptably high. And one reason are the capacity and capability issues. So in remote areas, one doctor provides comprehensive primary care for over 30,000 residents. So imagine that the regular checkups are not provided to pregnant women. So now our strategy involved task shifting. So we empowered lower trained frontline health workers. These are accredited social health activists, to take over some tasks that are traditionally performed by physicians with the help of a clinical decision support system that was in that case delivered over a tablet that the frontline health workers take with them when they go into the rural villages. We've now also shifted to telehealth during the pandemic. And the clinical decision support solution allows the frontline health workers to screen mothers and children based on the Indian standard treatment guidelines to ensure appropriate triaging, referrals, and advice. And we tested the clinical decision support solution with 50 frontline health workers in Uttar Pradesh in India. And what we found is that with the help of that digital solution, the frontline health workers were able to detect 300 high-risk pregnancies out of 1,000 screened pregnant women, or they were also able to recommend urgent referrals for 200 children out of 3,000 screened children. And we also did user research with the frontline health workers, and they reported that they really think this helps them to make the right recommendations and give the right advice. Also can improve the patient experience. I think we heard this in the previous discussions. It's the appropriate of a referral to go into a hospital. It has to be really appropriate, because otherwise the patient is losing his the wages of that day and has to pay for travel and so on. So you only want to refer patients to hospitals in the cities when it's really required.
Necessary.
And, and in addition, the solution enabled now a lot of data analysis that can be now used for population health management, but also for the team approach to improve outcomes, as we heard in also in the first in the first questions. And I think this is a good example of how clinical decision support can make a difference in the life of people in rural communities. We are now expanding into COVID-19 screenings and non-communicable diseases, and also accessibility over telehealth.
Yes, thank you so much. This is really interesting. I mean, it's very exciting to know that data and technology can make such a difference in people's lives, really. As you were speaking, my data brain started moving, and I was thinking, oh, great, they leveraged the knowledge of all these wonderful specialists, and they gave it to the hands of people who could just execute on it and reuse that knowledge, well, which is the data. And then I was wondering about the feedback loop. So like you said, they collect the data and they figure out, okay, how can we improve and give the right appropriate. So I think this is a wonderful example. Second question, outreach for the rural communities poses many challenges that the urban healthcare program do not, right? So they don't have to deal with it. Some of these are not only the access to the healthcare service, but also the challenge to get the message out about healthcare hazards and risks. So this is all about awareness and changing behavior. How does your organization address awareness and communication on healthcare matters with rural communities? And what role does digitalization and data play in your ability to make the campaign a success?
Yeah. I think similar to what Dr. Connie said. So also Elsevier recognized within weeks after the start of the pandemic, and also now with the emergence of the new highly transmissible Delta variant, that is maybe a good example of where you need to increase awareness of appropriate treatment and prevention and treatment measures. And we have launched a COVID-19 healthcare hub to help curb the spread of misinformation and also support clinicians. So this is a hub with free evidence-based resources that include localized online learning tools for healthcare professionals, but also for the public on prevention and management of COVID-19, along with evidence-based information on COVID-19 vaccines. Now, as we already discussed the good sides and the downsides of social media, on the other side, misinformation, such as falsehoods on COVID-19 vaccines, is often distributed on social media platforms. So we made it a specific purpose to share, to address the threat of misinformation and its impact on public health by sharing verified information on that hub, but also actively distributing it across social channels such as WhatsApp and Twitter to reach people wherever they are with evidence-based information on the pandemic. And the data that we have shows that alone, when we only look at India since May, since the second wave has started, over 15,000 medical practitioners and 5,000 faculty and members and students across India visited the hub, and we have often heartbreaking feedback on how helpful this information can be.
Great. Thank you so much, Laura. This has been incredibly insightful. And I really think that both you and Dr. Cooney talking about this outreach, it's really amazing to know that data is so impactful. Sorry, sometimes I'm up here in the ivory tower of corporate and only working with big corporates and big organized government. So it's lovely to know that this is really happening on the ground. I wanted to switch gears now and talk about the money, the money side of data. So Nora, you are highly distinguished, know so much about investment. I'll try to keep the questions brief so you have as much time as possible. Investment, question one, investment to get your health facility into the future is critical. How has data influenced your investment appetite for one investment deal versus another? Does the data play a material factor in the attractiveness of that investment deal? And investment has traditionally worked from an ROI formula, but how does this formula incorporate the value creating role of data in an investment object? And do you feel that your peers are aware that data can play a material factor in the investment equation? And what are your thoughts on this? Please go
Thank
ahead,
you.
Nora.
Thank you, Althea. So to respond to your question, I'll break it into different parts. To start with, data is a key for any investment decision. When I talk about data, we talk about the financial information, all the corporate information, all any information or data is essential for to make meaningful investment decisions. So when you are making such investment decisions, there are certain factors that need to be considered. To start with, what is the investment thesis? What is the rationale behind the investment decision? The strategic reasons or just expansion, etc. The next thing that it comes to my mind is what is the current management team doing there? How do they drive the business? What is their competency level? What is the effectiveness that they have in order, or the appetite for them to grow the business? The next thing that I look at it is, as the business got potential to grow their numbers. When I talk about grow their numbers in terms of both top line as well as bottom line, and then when we look at the business case, what is the historical numbers? What is the compounded annual growth rate? Looks like in terms of the top line as well as the EBITDA line. And then do they have corporate governance structures in place? Whether do they have an audit and investment committee? Do they have a remuneration, HR and remuneration committee? Do they have a clinical advisory committee? So various committees, do they really function properly? And then as the information that is being taken into consideration by these committees, are they been really critically looked at by the board? And then is the board really functioning to the expected levels of the shareholders? That's number 4. Number 5 is, of course, when we're doing the investment decisions, we have to do certain due diligence, as what Dr. Augusta talked about. So when we talk about due diligence, we have to talk about financial due diligence, we have to talk about tax due diligence and the legal due diligence to see whether does the business have any sort of hidden risk? And then if there's a hidden risk there, then how much is the risk? How much are we supposed to discount? What is the discounting factor? Everything need to be ascertained. And then after that, for any strategic investor, like say a PE fund, for argument's sake, when they enter into any business, they also come up with an exit plan in mind. And then based on the business case that is shared by the proposed seller, what is the expected IRR or the ROI that can be expected by the investor? Everything has to be considered. For all these things need to be done. Data is very, very critical. Without the data, it's very, very difficult to make key investment decisions. And then, of course, in order for me to get the above details, so I analyze the various data, the key performance indicators in the business, the financial results, both historical as well as the future performance, what is expected from the business, and then various analysis that forms the basis of that investment decision. And then the last part of the question that you're talking about, the peers, whether they are aware of the data, does that play a material factor in investment decision? Yes. Just to give you my, based on my last 25 years of experience in the various industries, be it in the hospitality, retail, healthcare, or the IT, what I always do is I always focus on ensuring that my peers, be it financial or non-financial members of the team, are very much aware of the data. So at the end of the week or end of the month, I always take them through the numbers to ensure that every member of the team is understand those numbers. How do that numbers come in? Whether it be profit or loss, or whether are we incurring more? What is our cash ratio, liquid ratio, and other things. So everyone has to understand. I always teach them finance for non-finance managers, so that people do understand the numbers. That is very, very critical. And then once that happens, those are the things that once the team understands those values of those numbers, they form part of the vision to achieve a certain result. Once they form part of the team of achieving that certain results, that forms the basis of the business case.
Got you. Yeah.
Okay.
There's power in numbers.
Of course. And then I always have a habit of, as I mentioned earlier, finance for non-finance managers. So I always have an habit of training and mentoring the team members, so that my learnings, whatever I have learned, is passed on to the next generation or next other team members, so that it doesn't, the good thing that I learned, it doesn't stay just with me. So that
No,
way I
no.
leave behind a legacy which speaks of my work, even though if I'm not there in a particular role.
Right, right.
So
Thank you very much for that.
That answers the first part of the question. Yes.
That's the first part. And I like the way you touched on the data, the information about the company, the health condition of the company, financial health, the risk factors, all via the data. And especially the last one, knowledge transfer, because knowledge transfer, knowledge assets are definitely data. It's a higher form. So thank you very much for that. I am going to tickle you a little bit because I am a chief data officer. I'm going to challenge you about the data estate. So the data itself is an asset, intangible, but it is an asset, just like financial assets or IT assets. They are an asset. When you look at the anatomy of that in a company, doesn't matter if it's a small one or big corporate, that would be another factor to determine the health and the wealth position or potential of a company. So that was also kind of a question that I was needling you there for, but thank you for your thorough answer. So I'll go on to the second one. This is about the investment in digital infrastructure, telehealth, and operational efficiencies remain on a strong upward trend post-COVID. As an investor, is there one or more investment themes where you consider data as a driving factor to determine the attractiveness of the deal? If yes, what are the things you look for to determine to lower risk exposure and capital assets that influence the value of the investment deal or object? I think you kind of answered me, but if you'd like to add, go ahead, please.
Thanks, Althea. Okay.
And we leave some time for Dr. Ralph as well.
Sure. Okay.
Okay.
Actually, in fact, COVID has taught us many new things in life. In specific to the healthcare, where life is unpredictable. People fall sick. Most of us are afraid to visit the hospitals, especially during this time, because we don't know who has got COVID and other things. And then again, as they might have a risk of cross infections. Because how many hospitals in this age do they follow the right SOP of ensuring no cross infections are being there? So that is the first thing. So this is where digital infrastructure like the telehealth, operational efficiency, everything comes into play. So as a business, we need to think differently to deliver quality of care at an affordable price. I remember earlier, Dr. Koni mentioned about the high pricing or the high technology. So that is what
high price. Yeah.
Yes. So we have to provide quality of care at an affordable price that can be achieved through proper technology that can be put in place. That is possible. So Africa as such in general is price conscious. So what I do is as an investor, I look for what technology that has been incorporated in any business, which offers a sustainable solution to our patients. Also, I look for what data is made available from such technology that has been implemented. See, thing is putting up a technology and then that doesn't give me information is useless. So whatever technology that I put in, there is an investment that I'm putting in right on those technology that will give me meaningful data, meaningful information for my team to analyze that number. So also I look for what data is available from such technology that has been implemented. Such data need to be meaningful, and then we should be able to analyze that information, and then based on those analysis, we should be able to make better investment decisions. And then this can generate better IRR or ROI. Of course, for non-finance people, IRR is internal rate of return, ROI is return on investment. So that is number 3. Number 4 is during the last 2 years when we had this COVID that we are all facing, both in my professional life as well as an investor, and then also as an independent board member currently at Infistrat Software Services, we ensure that our customers are provided with solutions that are effective and provide efficient solutions, also at an affordable cost. So that is what I would like to close my remarks as for your second question.
Thank you so much for that. I would just like to add one little thing. We always say in the data business, it needs to be impactful. The data needs to be meaningful. It needs to be relevant. it needs to be actionable, and it must be trustworthy as well as ethical. So thank you very much, Nara. Moving along to Dr. Oh, thank you, sorry. Moving right along to Dr. Ralph. Dr. Ralph, are you there? Calling Dr. Ralph in Lagos. Are you
Yes,
there?
good afternoon from Nigeria. Thank you very much. I'm here.
Thank you for this really amazing panel. I'm going to be quick with the questions so you can tell us all your thoughts. Two questions. First one, on healthcare ministries around the world experience hardship before the COVID pandemic, but what is your experience to establish the role of data leadership and information management, knowledge management as well, in your organization, which is dealing with so many life-threatening challenges as your core business? How has the role made a difference in the organization's effort to modernize the healthcare services from digital excellence, community outreach, to providing service outside of the hospital, such as telemed? Is your role and that of data seen as pivotal to achieve the organization goal? And what position does it play in addition to the many healthcare challenges? First question, Dr. Ralph.
Thank you very much. I want to really appreciate this platform given to me. I want to apologize for coming in late. I missed Dr. Augusta's presentation, but I was in when Dr. Cornell, Laura, and Krish was talking. And what I'm going to say is definitely going to be in line with what everybody have actually said. Just like you agree with me, Althea, you said something a while ago that data is becoming a very great access, not only to a particular country, but to the world at large. And from what I'm going to say, data is becoming much more expensive, more than the crude oil that the whole world is really looking into now, because the level at which it is going now, I'm so glad that the entire world is really looking and focusing on the importance of data. And coming down to the question, I'm going to talk in the context of Nigeria. I'm not going to, yes, I work with Lagos State Ministry of Health, but I am not representing Lagos State Ministry of Health here. But I'm going to talk as a consultant and what is going on as far as this question is concerned. In Nigeria, presently, the federal government of Nigeria is really making the data to be much more very, very interesting. They are taking it as one of the most priority that every state, not only the federal alone, every state must follow. And I'm glad to let you know that the Nigerian government have established an agency that is called National Information Technology Development Agency, which is called NITDA. And the NITDA has formulated what is called NDPR, that is National Data Protection Regulation. So which we are taking after the General Data Protection Regulation. In Europe. And this is really has been helping us. Now, in Lagos State, for instance, now, I'm glad to let you know that Lagos State is the #1 ministry in the entire country of Nigeria that will first be data and Nigerian Data Protection Regulation compliant. And just 2 months ago, we hosted the Director General of in Lagos State, and they came around. It was a very big celebration, and the governor of Lagos State also embraced this. And the most important aspect of it is that the governor of Lagos State is really making efforts to ensure that data is no longer treated as second-class material. Is taking it as a very wonderful priority to ensure that every nook and cranny, every health sector, not only the health sector, even the banking sector and every other sector, they are taking this very serious, because there are a lot of great penalty if you default, if you breach any data contract. So this is very, very important. Now, coming to the Ministry of Lagos, the Health Ministry, for instance, now, we know that without data, there is no how any decision can be made in healthcare industry. every decision making relies on data. And that is the reason why we just have to make sure that we handle data with care and give it a very top priority in whatever we do. So this is very, very important. And a lot of work is going on, even in the digital world. A lot of work is going on. The data protection is working hand in hand with the digital aspect of the government to make sure that things are worked out the way it should be. So now, and aside from that, we look into other area which is still related to data. In Nigeria presently, the digital healthcare system in the country is really ensuring that the EMR, that is talking about electronic medical records, there's a bill that is still in the process now that is about to be passed. And one of the problems that most countries in Africa is having is just to have a regulation that will be backing how data should operate, how data should be handled. And also, it's not really peculiar to other African countries, even in Nigeria, but presently Nigerian government and Lagos State government, they are working assiduously to ensure that everything that has to do with data is backed up with a lot of policy that is going to guide the use and operation of data in the country, so that the operation of data will not be abused by the user. So there are laws and regulations that are backing them up. Now, lastly, because we don't really have time, I just because people have actually talked about so many things, and I don't want to repeat myself again. Dr. Chronic, says something, Dr. Krish and Laura, they said something that's very, very important. I don't want to repeat them again. But what I just want to say now is that there is a need for people to be sensitized. There's a need for people to be trained continuously to have the understanding of the importance of data and the importance of digital technology in the healthcare system. So if this training can keep going on, not only in the urban area, even at the remote part of the country, people will have the understanding, and there's going to be a synergy. There's going to be an effective cooperation to make sure that this system works effectively, so that at the end of the day, we will all achieve what we have been dreaming to achieve. And lastly, there is no how we as a nation can actually bring this to come to reality. Every African country will need to come together to form a policy that is going to be a uniform. There's going to be a general policy that is going to guide every African nation on the use of data. And by this, I want to be very sure that everything is going to work effectively. Thank you very much.
Thank you. Thank you very much, Dr. Ralph. You really closed the shop very well. We've got a bunch of questions coming in from the audience, and I want to give the panelists a chance to answer full-heartedly. I just wanted to say in closing, Dr. Ralph, thank you for being quick. But that specific question that I had regarding the role of data leadership and the skill sets, you mentioned about training. It is so important that that happens. The last point you mentioned about a Pan-African, cooperation on this is something that I think should come up more as we go along, because as you rightfully said, data is the new oil. A lot of people say that, but I personally say data is the new soil, because soil is everlasting, so it doesn't run out. Anyway, going to the questions, we have a couple of questions, and our panelists are going to answer. Let me see here. I have the first question. How do we, the audience asks, how do we really standardize the style of data recording to make sure it's useful? And useful being used and reused. So Dr. Augusta, you wanted to answer that question?
Yeah, thanks very much for the opportunity. It's a really great question, because often we just digitize and create yet another process when we haven't really interrogated the value or the efficiency of the process that that we're using, which is collecting the data. And often we just collect data because we've always collected it. So we just carry on collecting it instead of stratifying it and making sure that it's contributing to the best possible health outcome for the patient. Good
Thank you very
question.
much.
Thank you.
Thank you. And the second question from the audience is, how do we really deal with the side effects of such digital technologies? And I think these are, it's kind of multifaceted question. Nara, you wanted to take the question.
Thank you. So any technology has its pros and cons. So one of the side effects we're talking about the stealing of data, or the importance of keeping it confidential. So there should be checks and balances for any technology that we have to implement when we implement solutions. So such solutions are being, when we implement, we work together with the user departments or the user organization, and then try and see how do we set up in such a way that, if, say, for example, the doctors are relating some certain information to the patient, that only the doctors and the patients are sharing that information. No other staff members or no other members outside these two people are accessing such information. So there should be some checks and balances that is defined as part of the setup process. So that is how it should be defined, or in infrastructure setup. Yes.
Thank you so much for giving that answer. I hope that they've got their answer. And then the third question we have from the audience is, though digital technology is a need of an need of an hour, okay, but how we make sure our healthcare workers are not exhausted with continuous introductions to such technologies. So I think in here there's a question about not over exhausting our resources, our human resources. And Laura, you said you wanted to answer that question. So please go ahead, Laura.
Yeah, so I think that is really a challenge, and we're seeing this. I told you about the 50 frontline health workers in India that we are working with to use a screening solution on a tablet, and it required a lot of training. But what it also requires on the side of the developers of these solutions is really to optimize the user experience. And what we do, for example, is we go with the frontline health workers. We understand how does their day look like with users of the solution and non-users, and trying to understand what are their workflows, what are their workarounds also from the official ways. And try to understand where does the screening solution fit in there. And does it maybe cut off certain workarounds that are essential for overworked frontline health workers?
Exactly. Practical things.
Very practical things. And only if you understand where the solution sits in the workflow, you can design it in a way that it can really help the users. And then you have to pay a lot of attention to every detail inside the solution to make it make the user experience as simple, as easy, as fast as possible, because we heard that these frontline health workers are completely overworked. They have to see so many patients a day. We cannot afford, they cannot afford to have a solution that takes more time than previously. So paying real attention to the user experience, understanding also where it sits in the workflow of the user is really essential. And it's not easy.
No, it's not easy. So we've got a limited time, and we've got two more people who are going to respond. So question number 4, how do we maintain confidentiality of data in telemed? And that would be Dr. Cooney, if you could answer that. And then we're going to go to Dr. Ralph to give a quick answer for the second and the third question. First, Dr. Cooney. Sorry.
In terms of telemedicine, whether it's done via a phone or via a chatbot or any kind of technology, I think it's important. Well, I think we all record those conversations for future liability, stuff like that. It's important to have your database safe. We, for instance, use cloud-based data centers that are supplied by Amazon Web Services and are highly secure and protected. I think it's also important in an organizational or business aspect to limit the number of people who have actual access to that database.
Yes.
You can't open up a database to all your employees. It's a job for one or two people. In short, I think that those are the two important things: a secure data center and limit the number of people that have access to that data. Thank you.
Thank you very much. So the proper purpose of use. Okay, and then Dr. Ralph, you quickly wanted to comment on 2 questions. Please go ahead.
Yes, thank you very much. On the side effects of the digital technology, just as we all know that digital technology has brought about a lot of innovation into the world today, but at the same time, you know, there are a lot of things that we need to be very careful when we're going to make use of digital technology. And that is why I mentioned earlier on that people need to be trained, people need to be sensitized to make them to understand the usage of this technology. A lot of people, you know, put their information, their data on the internet without knowing the side effects of what they are putting on the internet. And without letting people know how they operate, we'll still continue to have problems as far as digital technology is concerned. So proper training and sensitization is very, very important. Number 2, I mean, the question 3 now, you know, we're talking about the need of an, through digital technology is the need of an but now we can make sure our health workers are not exhausted. Now talking about the, you know, not how to reduce, you know, how the health workers, you know, are being overused in the area of digital technology. Laura says something that's very, very important here. But let me just add this. Now, there are a lot of problems that we're facing as far as digital technology is concerned. And that what is that problem? The problem is introduction of various solution application into the healthcare system. And when this is introduced, you know, most of these applications are not interoperable. They are different, you know, source program, which is really causing a lot of problems. And when the health workers are making use of different solutions, it is going to make them to be so exhausted and make them to feel so discouraged to continue. So what I'm just going to say now is that there is the need for us to have a uniform, you know, view as regards a solution, so that any solution that is going to be designed, that's going to be created, must have interoperability mode that will be able to work together with other solutions, so that the stress that is being placed on the health worker is going to be reduced. Thank you very much.
Thank you. Thank you very much. You're singing, it's like music to my ears. Really, interoperability is all about data first. Data is the system. And if we remember that, you've got to remember technology has a very short life cycle. That's why they keep on throwing the technologies in. They're helpful, but if we use the data to unify it all, we will never go wrong. Thank you very much to all of my panelists for your amazing contribution. It's been lots of fun speaking to you. I hope the audience enjoyed it as much as I did. And I'd like to say that as the managing partner of Turnkey Technologies, where we are the first, world's first chief data officer-led data management consultancy, I feel that the practical examples that you all have shared gives us more reason to exist and go global. So thank you very much. Thank you all for everything.
Thank you to all of you. Pleasure to meet you.
Thank you.
So much, all
I want to do it
Yeah.
again. Thank you. Bye-bye, Lagos, South Africa. Bye-bye,
Thank you so much.
Krishna,
Thank you.
Kenya,
Amazing.
Germany. Thank you. Thank you, Sneha. Thank you, Kuni. Thank you.
Thank you, Althea. Bye-bye.
We'll
Thank
hope to
you.
see each other soon again. Bye-bye.
All right, bye.
So we
Bye-bye.
already have Nara from our previous panel. Now he's going to share his presentation and he's going to share his view on building infrastructure to accommodate digital health and create opportunities for healthcare workers' skill set. Thank you so much. Over to you, Nara.
Thank you, Sneha. So I hope the members are able to see my screen. So
yes.
the topic here is building infrastructure to accommodate digital health and create opportunities for healthcare worker skill set. So when we go to that, first let's talk about the global agenda on digital health. Africa in the 71st World Health Assembly passed a resolution on digital health to ensure that digital health in the global arena is prioritized, and it was unanimously accepted. And then talking about again cooperation. So, what are the things that we have achieved so far? So, Africa has concluded the fourth summit of the Global Digital Health Partnership. It has the participation from 5 countries plus academia, industry, and startups. Adoption of the Delhi Declaration of Digital Health for Sustainable Development. Africa got the chairmanship of the GDHP to extend GDHP secretarial services. Now, next, when we talk about the African Digital Health Mission, which is the ecosystem as such, there are so many players that play in this process. Who are those so many players who come in basically? Basically, it's actually the policymakers. When we talk about the policymakers, there's government agencies, then the providers, which is the hospitals, clinics, labs, pharmacies, etc. Then allied private entities, which is the insurance companies, and then the next thing is the healthcare professionals, be it the doctors, the other practitioners, non-profit organizations like the NGOs, administrators like the program managers, regulators, etc. Why do they do all these things? It is to provide efficient services, which is accessible to the patients, which is affordable, and then timely service, and then basically a safe practice, and then inclusive of all communities. Then what are the current challenges that we face in the IT? Basically, the information is not it's not captured properly. So the data inaccessibility is another issue, that we have a duplication of data collection. So because of the systems not being properly set in place to ensure that the right data is collected, there is a data redundancy due to non-communication. No health information exchange of ideas is not available. Lack of common data analytics platforms. So for this to do, there is a healthcare system that need to be built for the future. So that will provide continuous monitoring, provide retail clinics connected at home, whereby the patients can access from wherever they are, auto patient access, virtual care facilities, omni-channel experience, intelligent treatments, virtual care team, connected care, coordinated ecosystems, augmented finding ways, seamless financing, etc. What are the digital health initiatives that has been taken so far? One of my in the previous panel, one of our panel members talked about EHR. So we need to create an EHR for the entire African people, the Pan Africa exchange in a secured manner. We have to set up the Pan Africa telemedicine network, currently which is not available at all. There is not even exchange of information between country to country. So that needs to be completely taken into consideration to ensure that we set up a Pan Africa telemedicine network. We need to use the optimal use of IT for the Pan-African surveillance and monitoring of programs. So that way we share knowledge and ideas and information, and then hence we capture things better. The efficient use of the IT tools for the capacity building and training, because currently the capacity and training is not available in Africa, which is available in the rest of the world. So that needs to be enhanced in Africa. The wide-scale deployment of the IT tools of governance and information. Currently, this IT sector is not regulated. The information is not available. There is no governance or process in place. So we need to take into consideration. So Africa undertook various initiatives in the digital domain for efficient health service delivery. So that is in process as we speak. So as part of the digital health initiatives, integrated health information platform. So web-enabled Africa-wide real-time network system is available now. So the data entry envisaged for more than health facilities. We cover the epidemic-prone diseases, predicting early outbreaks with advanced GIS mapping. So with so many countries in Africa have implemented that, but still quite a number of countries yet to implement that. So with that resulted in only 30% of the population in this continent is covered. Comprehensive primary healthcare program is essential. So for that, name-based population-based screening is required, which is already started in some of the countries. 5 non-communicable diseases like hypertension, diabetes, oral, breast, and cervical cancer, operational in almost all African countries. So 80 million enrollments have been done so far. Close to 13 million have been screened in this process of the program. Then the hospital information system, or HIS. So workflow based HL7 compliant is basically a regulation as per the WHO standards, and then the ISO IEC 9126 certified end-to-end solution has been initiated. An integrated HMIS suite consists of, basically we need to have HIS, LIS, RIS, PACS. PACS is to actually ensure that some of the equipments are integrated, thereby the doctors are able to read the results faster. Blood bank and telemedicine suite. And then this is built, the IT system is built on open source software tools and technology. It is implemented in more than 400 hospitals. Multi-million OPD registration has been done through the Digital Health Initiative. African Medical College Network. So far, 50 government medical colleges have been interconnected this particular network. There's a collaboration of networks of doctors and students. Tele-education is in progress. Remote learning, live surgery, CME, etc. So far, through this initiative, more than 2,000 sessions have been conducted. There is a teleradiology. We are talking about earlier. We talked about digital telemedicine, teleconsultation, everything. Similarly, teleradiology, providing remote radiology services through the services. That's again through the technology that is possible, and then it's been implemented in quite a number of hospitals in Africa as a continent. And then the patient need to be able to access their own health record. So this will enable them to know exactly what is it, and then they will be able to get a second opinion if required. So that has been implemented in a couple of majority of the hospitals, major hospitals in Africa. But again, this facility is not available to those hospitals which cannot afford to have those systems. So that is why, hence, we spoke about having affordable technology in this continent is very, very essential. And then one other thing that has been implemented in this continent is the online registration system as part of the digital healthcare thing. So then my hospital, so IT-based function is very, very predominantly required. And then that will give a patient feedback system, because at the end of the day, we need to get our customer feedback to ensure that whatever information that we get, and then we provide better services. Quality of care is very, very essential that we provide. That can be achieved only through digital health initiatives. Then we talk about the reproductive child health care. Facilitating care and support to the mother and child is very, very essential. And then eligible couples for reproductive and child health system. So eligible couples are about 20 million in Africa. Pregnant women is around 14 million, and then children are over 12 million. So that initiative has already been taken by Africa as part of the digital health initiative. Mobile service to deliver audio messages on pregnancy, childcare. Most of the, as far as I remember, based on my travel across Africa, in most countries, this has been implemented. Currently, it covers about 9 million mothers and the soon-to-be mothers as well. And 28 million outbound voice messages are being also sent. This is all based on the statistics that we've analyzed. And then there is a mobile academy. The mobile training course on maternal and child health is being carried out in most African countries. It is aimed at improving the knowledge and communication skills of the ASHA workers. Around 33,000 field health workers have been covered under this program. Now, going to the next slide, we talk about TB patient, because Africa has quite a number of TB population, TB patients. Basically, a web-based application is being initiated to monitor such TB patients. So in this particular monitoring system, 95% of the TB patients are covered from the public sector, and then over 11 million patients are notified so far. And then as part of the digital health initiative in Africa, we have started with the e-blood bank. Blood is essential in case of any emergency requirement, be it in accidents or whatever it is. So centralized blood bank management system is one such thing that need to be implemented. It's not implemented across the continent. It has been done in a couple of countries, but this needs to be centralized and then done across the continent. Biometric donor management system for identifying and tracking and blocking donors. because as all most of you know that HIV is there in most countries is in Africa. Of course, there's medicines being prescribed and administered to quite a number of patients on this. So for we cannot be getting blood from those HIV patients, so it has to be blocked for those people. Track the blood stock level across the numerous blood banks that is available through web and app based. So that is where the technology comes in handy. So more than 2,500 blood banks are currently on board. And then the cessation SMS-based initiative to help the tobacco user to quit tobacco. So as most of us know that the tobacco usage causes cancer, and then to quit tobacco, there's a SMS-based initiative that has been initiated in majority of the countries in Africa through the digital-based. It is being done in collaboration with the WHO. Currently, more than 50,000 users have been registered in the platform. So digital platforms are forming a critical role in these things. Now, what is happening with the drug and vaccine distribution management system? Currently, that's one of the major things that we are facing in like in COVID times. Automating the workflow of supply chain of drugs. That's to achieve a reliable and accurate information of demand and forecasting ordering. So currently, the so many countries in Africa still have not got uh, COVID vaccine for the entire population. So people are still going very slow. So it's currently this particular management system is implemented only in 8 countries in Africa. So that is very, very low. So we need to ensure that the e-vaccine, they are so digitize the vaccine stocks and monitor the temperature of the cold chain through a smartphone application. That is essential. That is still in process. It has not done much about it yet. Only few countries like South Africa and few others have started initiating that process. So it's still underway. Providing real-time information on vaccine stocks and flows and storage temperature across all cold chain. Then it's over 6,500 cold chain points digitized across 3 countries. That has been done so far. It's all from the statistics that we have taken these numbers. It can be cross-verified. So again, to continue, over 4.5 million online transactions are being done every month. So what are the standards that we talk about? So notified revised electronic health record standards 2016, initially, which is in 2013, that has been in place. Procured, so things are happening in terms of how the procurement of licenses and other things. And then African Health Resource Repository. So this is very, very essential with a vision to create a comprehensive and robust registry with the details on infrastructure, services, patient load, GIS, etc. Over 25 lakh health facilities were estimated to be covered across countries. Currently, only 60% of the health facilities were successfully verified with over 4,000 data sets as per the facility. Identification number of in the African continent. A unique identification number and a key requirement for achieving the interoperability and the creation of EHRs. So 99% of the public health facilities are allocated with a identification number. So now for again talking about digital transformation, governors, how they release the telemedicine practice guidelines. This is more prevalent. This is quite prevalent currently in South Africa alone. The other countries in Africa have not implemented some of these things. So they allow the registered medical practitioners to provide healthcare facilities through telemedicine. Talking about telemedicine, unlike European countries or US, any developed country, Africa is still backward in a certain way that people are still wanted to have a face-to-face discussion with the doctors or the consultants. they don't understand the importance of teleconsultation or telemedicine. It is still patient experience that need to be embraced, and then we need to coach or train the importance of teleconsultation, which is currently this is quite popular in South Africa, but rest of Africa is yet to be embracing this telemedicine. In South Africa, again, e-Sanjeevani application modified for providing online consultation to patients were directly implemented. Now, this journey from African digital health blueprint, so that is a transformation by itself of how the extensive deployment of digital tools for improving the efficiency and outcome of the healthcare system to Africa recognize the need to have a framework. Because unless until you have a framework of how do you implement a certain technology, and then this needs a governance or a complete framework that need to be developed for the entire continent for them to follow through. There is a framework that has been in discussion, which is being once it's done, probably early next year, it's likely to be implemented. This blueprint is talking about the African architectural framework, covering a disparate health information system, federated architecture, open standards, unique health identifiers, privacy and consent management. Earlier in my other panel, they were talking about how do we protect the data. So here we are talking about the privacy and consent management. So African portability, EHR applicable standards and regulations. So unless and until regulations are in place, people can misuse these health information systems. So that is very, very critical. So those are the things that's being developed right now as we speak in Africa. And then various analytics, health analytics, proposing AI, blockchain technologies. AI, blockchain, these are all very, very prevalent in the other part of the world. But in Africa, it is yet to be fully implemented. So we are talking about AI and blockchain technologies right now. So multiple access channels like the web, mobile call center, telemedicine, digital health Africa portal, and my health app, etc. So those are things that is yet to be embraced in Africa as such. Yes, quite a number of countries have already gone to that stage, like South Africa, Kenya, and few others. And then, but majority of them are yet to do that. Going to the next slide. So what is the vision that of the Africa Digital Health Mission is to create an Africa Health Digital ecosystem that supports a universal health coverage, which is efficient, accessible, inclusive, affordable, timely, and self-manner, and a seamless online platform through a provision of wide range of data, information, and infrastructure services, duly leveraging open, intolerable, standards-based digital systems that ensures security, confidentiality, and privacy health related information. Now, talking about the same thing, Africa Health strategy needs to be issued. This is still in progress. The guidelines for the health information provider or the health information, it's being again done through various partners, stakeholders are involved in this process. There is an implementation strategy that's put in place, covering 3 different phases. Of course, these are all quite detailed, so I don't want to go through all the details, but nevertheless, for the users or the people to understand, so there are 3 different phases that is being covered. And then this basically goes through the health ID, digital doctor, health facility registry, personal health records, as well as the electronic medical records. Now, what is the way forward? What do we do? How do we address this? So we need to establish an African digital health ecosystem in every country in Africa. So integration of African and state programs in a common framework under the network is very, very crucial. Ensuring the longitudinal health record of the patient across the healthcare spectrum. That is also, again, very, very essential. Establishment of a telemedicine system to cover each and every health facility. Position Africa as a world leader in digital health. People consider Africa as an underdeveloped continent, which is now currently changing. This is part of the emerging segment, so which is now being positioned as a world leader in digital health, ensuring appropriate inclusion of disruptive technologies in health programs. Disruptive technology have not been penetrated in this part of the world, but that's being exploited currently by some of the players in the market. So there is a move from silos towards more citizen-centric health service delivery and continuation of care. So there is a lot of IoT or the internet over threads connected devices are being in place. So this, of course, this chart will provide more information, but with the time that we have limitations, so I cannot go through all the details, but I can share this information if someone needs it. So there is infrastructure services through cloud migration. Of course, with the changes in technology, cloud is the next way to go. Instead of you putting up everything in a server, you might as well store the information through a cloud. So migration to the cloud is the next stage. And then this is done through a Salesforce, the health information, health cloud, and the case study. So again, as part of this exercise, we have done a lot of case studies as myself being an independent director of InfiStrat. So based on that, of course, I can share this information separately on a user-based requirements. So that is all about what we do as InfiStrat.
Thank you so
unless
much.
Until any users, sorry, say again.
Thank you so much, Nara. We have to really move on. We really have a time crunch over here.
Sure.
Thank you so much once again for such an enlightening presentation. Thank you.
Anyone has any questions or anything?
We will take it up on the platform because of the crunch of time.
Okay.
Perfect.
Sure.
Thank you. Thank you so much.
Thank you. Thank you. Bye-bye.
Bye. Now we have Majid, the head of Clinical Decision Support Solution, Elsevier, and he's going to be sharing his views on the dynamism of clinical knowledge. What are the solutions available for the clinicians with current IT infrastructure? Over to you, Majid.
Thank you very much, Sana. Just please let me know if you see my screen.
Yeah, I do.
Great. Thank you very much for the introduction, and thank you everyone for joining us today in this session. So as Sana said, I'll be walking you through a presentation focusing on the dynamism of clinical knowledge and what are the solutions. My presentation is built on a thought leadership piece that was developed by our Chief Medical Officer, Dr. Ian Chan, which I would like to thank him very much for such a great work. The agenda today is that I will walk you through the growth of medical knowledge, the complexity of advancing knowledge, use case research white paper that we have developed, and the clinical knowledge needs, which we identified in educate, identify, inform. And at the end, providing you with a solution that can support clinicians in practice. Clinical knowledge is never static. It keeps changing, evolving, and also what we know about human body and science is constantly changing and evolving. Fundamental principles and core knowledge keep shifting, and we can see that clearly from the pandemic that we're going through. Also, we'd like to share with you some interesting statistics or numbers that focuses on the doubling time of the sum total of medical research, which means what is available out there in terms of research and knowledge, how long does it take to double? So all what we know about medicine used to double every 50 years back in the 50s. And in 1980, it takes about 7 years for that to double. In 2010, about 3.5 years. And in 2020, every 73 days. So every 73 days, everything we know about clinical knowledge is doubling. And this is a huge amount of information that, becomes a challenge for clinicians to keep updated and recent with. Clearly, with the COVID-19, we can see the pace of the medical knowledge, how it shifted. For example, at the beginning of the pandemic, we knew zero probably about COVID-19, and things kept changing by the day and by the hour. Clinicians had to treat patients, learn at the same time, which was completely a very challenging thing. And COVID-19 is still prevalent and probably will stay with us for a while. So this will continue as well to be a challenge for us. Now, the complexity of advancing knowledge is ever expanding, and this is also causing and raises challenges for clinicians. The information that the clinicians are accessing is now complex, it's multidimensional, and also varied. For us clinicians now, we look at them as if they are pilots who are building and maintaining an airplane while in fact actually flying that airplane. In order for us to understand how clinicians are currently using and accessing information, we've conducted a global survey that covered around 507 specialists and clinicians. And we asked those clinicians how they access information. We're trying to learn and understand that. We've pre-identified actually 7 questions, actually 6 questions or pre-use cases for those clinicians. And we asked them, which ones do you relate to more when you're accessing information? So the use cases are mainly, the first one is to find, you use information or resources to find quick answers in between or during patient consultations. The other use case is to develop or confirm assessment and a treatment plan. The third one is to keep abreast with the latest thinking in the field. The fourth is for learning purposes, and then for teaching purposes, which is to teach others. And lastly is for clinical research. For example, if they are writing articles or doing clinical trials, etc. And from that survey, we found out that the majority of the clinicians are actually using or looking for information when they are patient-facing or inpatient-facing scenarios, like if they want to find information during a patient consultation or to develop or confirm assessment. And when they are looking at learning purposes or for teaching or for clinical research, they tend to focus more on the quality of the content they are looking at. And also that, from the research, we found out that many clinicians start their search on PubMed, on Google, and even on Wikipedia, which is not evidence-based and sometimes can include an error. So we can notice that clinicians are facing issues in finding quick, right information at the point of care from a reliable source. So to wrap up, traditional models will no longer hold up. Medical education and skills development now must adapt, and structured and reactive learning will have to blend. When we look at the clinical knowledge needs, we actually group them or categorize them under 3 main categories. The first one is to educate, which is the core foundational knowledge. The second one is to inform, the key practical knowledge provided. And the third one is to identify, which is the prompt information or to confirm an existing information. Education is quite easy, and to be educated and updated with the latest information. A great example of that is continuous medical education, CMEs, or actually we're looking at medical students. Now, to inform is basically to get the relevant, needed information at the point of care when you need it. And a great example of that when a doctor is in a patient consultation during their working day. The third part, which is to identify, this is just to confirm an existing information or pre-existing knowledge that they have. For example, a doctor would know how to treat a patient, but they need to confirm what needs to be ordered, for example, or what treatment plan that patient needs to be put on. So that type of information. At Elsevier, we've taken that highly into consideration, and we developed our clinical solutions to actually meet those needs, from education to informing or to identifying. And these are examples of the products that actually designed for those needs, like clinical key for students or clinical skills, where people can go in there, look at the latest research, look at the latest articles, guidelines, etc. And then also when they want to be informed quickly about information, they can go in there as well on clinical key and get the short, relevant answers at the point of care when they need it. And lastly, to be to identify and confirm information, this is where we prepared for them order sets for physicians or care plans for nurses and allied health, or patient education that they can hand to the patient. Today, I'll be focusing more into the inform and identify part. So when we want to find short, relevant information, there is key things that we need to take into consideration. The clinician is really busy and they don't have time. They are looking to find the most relevant answer in the shortest time possible. And this is where solutions, reference solutions like the one that you can see on the screen, for example, Clinical Key, can get you quickly the right answer because it's smart enough, it understands the physician's workflow and how they look for information. So for example, if they are looking during their practice, they need to quickly to find what's the latest diagnostics around ischemic stroke. They can just start typing. Within seconds, this topic will be suggested to them. They can click on it, and then, for example, a clinical overview will come up. They will not have time to go into a book or a journal to actually read theirs, so they need those short, important information at the point of care. So they will find synopsis, diagnosis, treatment, complications. They can click on what is needed, for example, diagnosis, and they can go to it. And this will take them probably seconds or very short couple of minutes. Accessibility is an issue, and we understand that not in all of the countries that we have great infrastructure, or the hospitals that we work with do not necessarily have the highest advanced technologies. They don't have EHRs, or they don't have probably sometimes internet. But what's good with the latest mobile technologies is that we're not dependent anymore on our institutions. We have our mobiles with us, and we can access information whenever we need it by the touch. So these solutions adapting to these technologies by having mobile apps or being mobile friendly give us that flexibility to access it anywhere when we need it. The second part that I want to talk about, which is extremely important, is to identify, which is to help clinicians confirm the knowledge that they have. And sometimes we will notice in big institutions that we have a variety in practice. We will have physicians practicing either differently, or they have a different background or education. Standardization is important, and confirming that information for them is important. So we can look, for example, about order sets or care plannings or patient education. Quickly, an order set as a concept. The definition of an order set is a group of bundled standard ordables. And when we say ordables, ordables are healthcare providers' instructions or directives to other healthcare workers regarding the treatment of the patient. So, for example, an order set for a pneumonia consists of what needs to be ordered for that patient who has been diagnosed with pneumonia, from lab, radiology, medications, etc. So it will be sort of a checklist for the clinicians to go through. Again, this is just for them to confirm their knowledge and not to actually teach them how to practice. Quickly wanted to show you an example of an order set because they are extremely important and they can act really as a safety checklist for everyone. What you have on the screen here is an example of an order set of how we structure it. This is, for example, for a sepsis ICU. You will see on the left-hand side sections, and within these sections, you will have the order items that the clinician can order from. So we are in the medication section, and this is where you have the antibiotics that you can order from. You can change and go to IV fluids, vital signs and monitors, etc., and click from there. But what's important about this as well is that it's not only about what to order, it's also about the evidence and the knowledge there. So you will notice, for example, that we add short type of advisory, which says that you have to begin IV antibiotics as early as possible within the first 3 hours when you're ordering antibiotics. Also, we add more advisory or short or longer guidance that you can read within 90 seconds. You can have sources that you can read from to see where that article came from. You can link it also to quality measures. So it's really very informative and confirms how physicians can practice. Again, the access can be an issue, and of course, the optimal use of it is to have it integrated into an electronic health record. But also, it can be used as a PDF, as a paper, having them at the hospital there for residents to go through all the time to make sure that they are following the protocols. And last thing I want to talk about, the last thing, is care planning as well, because it's not only physicians who need to confirm information. Also, nurses and allied health needs to confirm that information. So we have care plans that we prepared, and care plans basically is just a written reflection of the process, the healthcare process. So it has the assessments, the diagnosis, the planning, the implementation, and the evaluation. So for a nurse, they need how to assess if a problem is active. And once you assess, there is also a nursing diagnosis that you identify. Then you put a plan in place, and you identify what problems are there. You implement your plan by interventions, and then you evaluate. Again, sorry for that. Also, when it comes to taking care of patients, it can be complex. And I want to share with you a quick example of Rosa, for example. Rosa is 92 years old. Rosa is admitted to the hospital with pneumonia, but with her age and previous conditions that she had a heart failure. So to take care of Rosa, as the nursing team and the allied health, they have to consider the following problems that she can be at risk for. If she has COPD, so she's at risk of these problems. She's diabetic, she's at risk for these problems. And then with the pneumonia that she's admitted with, she's at risk with the following problems. Generally with her age and her condition, she's at risk with the following problems. So imagine Rosa, in general, there are 16 problems that we need to look at and consider. So having tools that can support the team in identifying these problems, listing for them what interventions are needed and how to take care of them is quite important. So this is an example for how, let's say, pneumonia can be. This is a guidance for the care plan of pneumonia. It consists of an assessment, the interventions, and what intervention needs to be done, etc. So, and again, the perfect use case of this is to be integrated into electronic health record, part of the nursing documentation, but also this can be as a reference tool that they can access on their phone or on their desktop. Lastly is patient education. Again, clinicians need to educate patients because patients nowadays, they can go online and look for information at whenever they need, and it's risky because patients can look for wrong information. And educational material that we provide to the patients are extremely important. And you can have materials from the discovery to the diagnosis following the patients in their journey. And this can be a text that you can print and give it to the patient. With the technologies that we have, mobile apps, you can send it to them. You can even send them a video that they can watch. So this is also extremely important to confirm what you need to educate the patient about. Again, that can be in different formats. So that's my presentation today. We wanted to highlight the massive amount of knowledge that we're facing and how we're handling it and what type of solutions can support clinicians in such cases. And I'll leave it now if there are any questions.
Hi, Majid, we have a question. And the question is, how do we migrate unstructured medical health records into cloud system? Thank you.
Yeah. Now, unstructured medical healthcare records can be a challenge. And that's why using order sets or using care plans, it more structures your content that you have, and it helps you build it in a cloud system that you can run reports on, make more use of it. But unstructured medical health records can be sometimes a challenge.
Thank you so much for keeping it so brief, and we really happen to enjoy your presentation. I'm pretty sure our audiences must have got some great ideas and would definitely visit your booth on platform and would try and check out the the solutions that you happen to provide it to us. Thank you once again. Thank you so much.
Thank you. And if you want to receive a copy of the Dynamism of Clinical Knowledge article, please feel free to connect with me, and these are my contact details here.
Sure, we'll pass it on to the audiences as well. Thank you so much, Majid.
Thank you.
Thank you. And for the last presentation of the day is brought to you by Sudesh Sivasru, Associate Professor in Biomedical Engineering, University of Cape Town. And he will be talking about improving patient safety in the ICU using innovative medical devices and ICT tools. Over to you, Sudesh. Thank you.
Sneha, please confirm if you're able to see my PowerPoint.
Yes, we can see that, but can you put it on slide view, please?
How about now? It's on
Slide
slide view.
Yeah.
Are you? Is it still not on slide view? Because
no,
on my side it is.
No, it is not.
Just hold on. How about now?
Yes, it is. Thank you.
Oh, perfect. Thank you, Sneha. So good morning, good afternoon, good evening, whichever part of you are. My name is Sudesh Sivarasu. I'm an academic at the University of Cape Town, and I head the medical devices research at the Faculty of Health Sciences in the University of Cape Town. And I'm here to talk briefly about some of the interventions and potential solutions related to ICT tools, and also in the way in which medical devices and medical technologies are actually made, and with respect to improving patient safety, and especially around the ICU. Before going on to that, I want to briefly touch on the background of the problem, where we are looking at access to lack of medical technologies. That's been a massive problem in many parts of the world. And so according to a recent report from WHO, 2 in 3 people globally lack access to essential medical technologies. And this does not exclude Africa, does not exclude Asia, does not even exclude some of the developed countries that are on the list. So this is a problem of a national and a global scale, and we need to look into this very carefully, and the ways in which we have been solving problems, and understand the reasons why these solutions have actually not landed on the needs of people who need them the most, and for which we need to understand the context where these medical solutions have been designed and developed. So this is a more recent picture where we're looking at people in queue for medical oxygen supply. And this has become a harsh reality where people kill each other or abuse each other for getting access to medical oxygen, and that's become a reality in our times. And we would like to understand why such shortages of essential things like medical oxygen actually happens. Because without medical oxygen, of course, many of the surgical procedures, or leave alone ICUs, even a general general medical care facility dealing with COVID may not be able to be sustainable. And when you try to explore to understand whether the problem is actually the lack of medical oxygen or medical oxygen supply, the problem unfolds as a multidimensional problem. So first, we need to understand whether we have enough oxygen concentrators. The answer is yes. Globally, there have been enough oxygen concentrators, and we've never had this kind of a shortage issue anywhere. But in India in particular had this massive, shortage of oxygen, and how did that happen? And then it then boils down to the issue of what happens between oxygen generation to how oxygen gets distributed to the people who need it. And then that kind of brings out the supply chain issues, which needs to be factored in to which has actually become a bottleneck when it comes to the oxygen supply for COVID in India. And we have had a similar experience in South Africa, but South Africa positively managed it in a much better manner because they were able to put out structures which could keep a track of the needs and how it is being handled, the needs of oxygen and how the supply of oxygen has been handled. So this problem actually makes us realize that we have been dealing or we are solving problems in isolation. So we are doing things in isolation, but that is not creating an ecosystem that is conducive for progressive healthcare delivery. And the picture used here, inspired from one of the professors from PGI Chandigarh. He uses this to illustrate how everyone in the picture, are doing things on their own. There is no like they on their individual capacity, they're doing fine, but at an organizational capacity, it looks quite chaotic. So this leads to our problem, where we are looking at majority of imports, of medical devices, which kind of burdens the taxpayers, with over 90% of medical devices being imported, and we are having unemployment of brilliant engineers, and the lack of innovation ecosystem actually curtails further progression of the industry, the engineers, as well as burdens the taxpayers in a much complicated manner. So one of the proposed solutions for this system is how we innovate. So we are going with a system called frugal biodesign, which is adopted in South Africa. So where the innovation methodology starts with the fundamental uses of medical devices, which is clinician. So unlike traditional practice where we look at the patients for the innovation, frugal biodesign emphasizes on clinician being the center of innovation, and uses a very streamlined medical device product development pipeline, and then uses intellectual property management, commercialization strategy, regulatory and reimbursement strategy to understand who's going to pay for these technologies, and by creating public awareness. So from the traditional clinician based model to the patient-based model to the clinician-based model, that is the shift. So what have we done? So my team at UCT, in partnership with CSIR South Africa, won the bid for the National Ventilator Project. We were part of the design team, and the design that you see to be adopted nationally, and then over 18,000 ventilators are being made, and it is used for the COVID waves 1, 2, and 3. If you look at the principles of how these, how the CPAP system evolved, it will be quite interesting to note that the usage has moved from complex electromechanical systems to a simple Venturi-based mechanical system. So that is one of the rural clinics may not necessarily have the electric supplies, or the complicated infrastructure requirements, so which may be needed for a full-fledged BPAP or a CPAP system. Success stories about how this has been assisting people in South Africa. So what we also understood is that we need to regularize and we need to standardize the requirements when it comes to testing of equipments, because safety is one of the key aspects. When I teach medical device design to students, I kind of emphasize on two pillars of medical devices. One is safety and the other is efficacy. So if you look at how the safety of the devices evaluated, one of the key factors that regulatory bodies or compliance bodies usually looking for is how well is the device designed and how well is that compliant to the place where it is going to be used. But what we also need to understand is we need to factor in the usability of these devices. How well is this device going to be used by the intended users who are handling these devices? Because you might design the best, you might design the Rolls-Royce version of a ventilator, but if the person who's on the ground is unable to use it appropriately, it might end up creating messing up the whole system. So we need to factor that in the design, and for which my team had developed this formative usability trial, which has been now used for several ventilation-based solutions in South Africa, and that is used for SAPRA approval. So currently, there's a consortium led by UCT, which is working, funded by Mercita. It's a multi-university consortium that is working on developing a BPAP solution. And this BPAP solution is essentially looking at ways of solving issues around around a BPAP solution. And we are also, in addition to designing a BPAP machine, we are looking at training students in the space of medical technology, medical device manufacturing, and bridging the gap between academia and industry. Another solution that I want to highlight is a very simple open source solution that was developed as part of our effort for COVID. It's a simple face shield. It's a no-brainer, but then we wanted to make sure that this reaches the far ends of the country. So we rather chose more manufacturable, more scalable solution that can be used and built with household items. And we have had massive success with this particular solution. And the lesson learned from this solution is that you don't necessarily have to over-engineer things. You've got to keep it simple at some point, and you've got to make sure that people who need it are able to get access to it. The accessibility of the technology is super critical while you're designing a solution. So I want to quickly jump out of the COVID-related examples to one final example around women's health. So this is to do with a procedure called hysteroscopy. Hysteroscopy is a procedure that is used to visualize the anatomical abnormalities of female uterine cavity, and what you can see on the picture is how a typical hysteroscopy procedure is handled. As you may see, it has a large. It's usually done in ICUs with multiple equipments around the hysteroscope, and has multiple light sources to equipments like surgical equipments that can go into the hysteroscopy and do things that are actually needed. And once you find an abnormality in the uterine cavity or in the endometrium, you might want to do a procedure to remove this or remove the abnormality. So one of the critical gaps in the space is that the access to one would have to wait even up to 6 to 8 months, or sometimes even a year, to get access to one of these hysteroscopic clinics. And then you will also notice that the procedure is not cheap. It's quite an expensive process. So what we came up is an alternate to this complicated hysteroscopic procedure, to something that is handheld, to something that is flexible, to something that can be used in a outpatient department. This is a solution called Flexigen that we are presently busy evaluating in the clinical trials to push it into the market. And we noticed that the system is quite sleek, and because of the miniaturized nature, less than 4.5 millimeters of the tip, and the smart bending mechanism that the technology has, this can be the solution can be used with just a local anesthesia, and you don't need a centralized anesthesia for using a solution like this. And on top of it, it also has it is connectable with mobile systems, so you could potentially record and manage data or the scan data and pass it on to experts. And more importantly, this can be done even by a GP. You don't need a specialist surgeon to do the procedure. So currently we are in the process of exploring this into a commercial solution, and we are looking at ways of how adopting the latest techniques and technologies and incorporating them in the design process. As you can see, it went in from the various developmental stages, and we are looking to expand this further. So my last slide for today's presentation is about what we learned from this exercise of the various exercises that we have been dealing with, is the fact that in order for your solution to be usable, in order for your technology to be adaptable in a clinical environment, your design team needs to be agile in a nature that it could, you can potentially learn from anything and everything out there. And collaboration is a key aspect, and integration of the solution to the rest of the clinical environment is crucial. And with that, I would like to thank you. Thanks Digital Health Africa for this opportunity. And thank you, Sneha.
Thank you so much, Sadesh. But we have a question out here for you. So we have a question that says, how do we really train our ICU workers when we have so many options available? Thank you.
So that's a great question. So when we have so many options available, are they? I'm not sure if that is meant to be like the virtual training options or many of the platform options that are there. But I think one of the essential things to start with would be, training the ICU workers with physical dummies, and that is a practice that we can see in many developed countries, where they end up using like physical equivalent dummies to do mock surgeries or to do mock preparations for surgeries, and that might be a very hands-on and more practical way of doing with the real life dummies. And that's one. And the other thing is, if you are associated with a tertiary educational hospital, you might as well, after seeking appropriate ethics clearances, you might as well practice or trial surgical procedures and surgical preparedness on cadavers. And that might be one other way to look into training our ICU workers.
Perfect. Thank you so much for such an insightful presentation of yours. Now we move to the last panel of the day, and we have, of course, you moderating that panel. And now we're going to conclude the day with a panel discussion on Industry Revolution 4.0, and we're talking about emerging trends and opportunities in digital health. It is, of course, moderated by Sadesh, who is with us and who has given an interesting presentation. And we move to our panel members. We have Benjamin, founder and lead blockchain consultant from Chain Advice Blockchain Advisory. We have Bukosi Sambo, head of digital solutions, MedSchemes, Afrocentric Group. We have Dr. Wuma, acting CIO, Department of Health. We have Althea Davis again. She's a country ambassador, UAE, and board of members, International Society of Chief Data Officer from Turnkey Solutions. And we have Clive Daniel. He's an independent health informatic and imaging informatics consultant and trainer from Into Space. Thank you, everybody, and over to all the panel members. You can switch on the camera and unmute yourself and introduce yourself. Thank you.
Thank you very much, Sneha. I'm just waiting for the rest of the panel to switch on, but it's before while we wait for others to switch on. So I might want to maybe I'll introduce myself and what is my interest in this Industry 4.0 panel. It's a complex world where we are living in, especially with the advent of industry or fourth industrial revolution. I think one of the biggest opportunities that I see with the fourth industrial revolution in the healthcare space is that it kind of bypasses the requirement of physical infrastructure, which is actually the fundamental of the first and second industrial revolution. And fourth industrial revolution actually offers that. So we can already see the physical barrier in terms of industrialized nations and non-industrialized nations. And fourth industrial revolution actually opens up the avenues for everyone and everyone to be on the same level. And that, I think, is an excellent platform. And with healthcare, it actually even opens up multifolds of opportunities. And that's my interest. And I feel that there's a lot that the medical devices industry, the medical technologies industry can actually benefit from the fourth industrial revolution. So changing our attention from fourth industrial revolution to industry 4.0, how well are we prepared and equipped for this industrial change would be a key focus on today's panel. So we can go for a quick round of introductions, starting with Benjamin Aruda. I'm just going in the order that's on the list. That is okay.
Thank you, Shit. And for this chance, it's really a pleasure to attend this conference as a panelist. My name, as you've said, is Benjamin Arunda. I am a blockchain expert and the lead blockchain consultant at Chain Advice Blockchain Advisory, based in Nairobi.
Fantastic. Thank you, Benjamin. Then we have Wikosi Sambo.
Thank you, Sudesh. My name is Fuku. Some insurance organization and medical aid administrator and risk management solutions. So I head the data solutions for the group, responsible for the enterprise-wide governance and framework of measurement and data strategy at large.
Fantastic, Wikosi. Great to have a fellow South African on the panel. Next to Dr. Wuma Makwanga. Dr. Wuma, whenever you're ready. We may have some connectivity issues, so maybe we can quickly jump to the next panelist, who is Althea Davis. By now, you must be familiar with Althea. Althea?
Sorry. Yes, I'm here. Sorry. Little elapsed there. Hello. Greetings, everybody from the UAE in Abu Dhabi. My name is Althea Davis. I am a 6-time Chief Data Officer, and I am a board member of the International Society for Chief Data Officers, a global organization bringing together over 1,500 Chief Data Officers and expanding. And I am also the Managing Director and Chief Data Officer of Turnkey Technologies, which is the world's first Chief Data Officer-led data management consultancy. Thank you.
Fantastic. Thank you. Thank you, Althea. So next we have Clive Daniel.
Thank you very much, and well, thank you for inviting me to this particular conference. Yes, I'm a health informatics and imaging informatics consultant, working mainly in the imaging informatics space. I'm currently president of SAHIA and also chair of the Private Healthcare Information Standards Committee in South Africa, and dealing with electronic health records. And my main interest and focus is in deployment of solutions and also interoperability and how we these types of technologies to talk to each other. Thank you.
Fantastic, Clive. So we have yet another South African. I'm so happy about this panel. So let's wait for Dr. Vuma Makagwa. So Dr. Vuma, if you're available. If not, I think let's get started. We will then invite Dr. Vuma when she is ready. So I basically wanted to start off this panel discussion with what Althea mentioned in the previous panel. She started, it was quite, mind-opening because she mentioned data is not oil, data is the soil. And, coming from Africa, you kind of value the meaning of soil. And it's fantastic to hear dimensional change of how, we are going to be seeing the crux of the Industry 4.0, which is data. And that's an excellent introduction to the whole in fact, it's a summary of what we are going to be dealing in this 2 days conference. Althea, thank you so much for that. So I would like to put forward a question to Clive and Vukusi on your understanding and your commentary on the technical adaptation of healthcare digitization, and how do you see it pre-COVID and post-COVID? What has changed and what has not changed? Maybe Clive and Vukusi can go for it, and then we'll have the rest of the panel address it.
Cool. Happy to start on my side. Okay, thanks, Clive. Happy to start on my side. So with obviously med scheme, so we are more on the private sector side of things. What I think happened when we first went into COVID is obviously we all had to accelerate to kind of amend basic things like provision of virtual consult from a healthcare perspective, as we're all obviously in the lockdown, was really the main priority. And obviously in the South African context, and I think for most countries, one of the things was that we're all overly optimistic as to how short-lived or long-lived COVID will be. And we are here now 18 months later, and we all realize that this is going to be with us for much longer. And the realization is also starting to sink in that even post-COVID, the world is just never going back to the pre-COVID normal. And I think now the conversation is moving to start thinking much more broadly instead of like just putting the pampering on the cracks to ensure continuity. And now data is trying to, and in the really means beyond just saying we need to make sure that we keep the lights on. For our members, for our stakeholder community. So I think that for me has been the highlight of the changes that have happened in the last 18 months from a private sector perspective. But I think all key players, so us, Discovery or Momentums, have done really quite well to keep our members going from adapting the technologies that ensures that our members still get their basic services and care. At a basic level, but I think there's obviously a whole lot more that can be done in terms of improving access, quality of health outcome going forward, and continue to digitize the sector.
Fantastic, Vukusi.
Clive, you can go in.
Clive?
Thanks. So thanks very much. I think that there's no doubt that COVID came along and it has rapidly developed and allowed for opportunities for this fourth industrial revolution to mature itself. So what are the factors that have actually impeded that? One is about rapid development. So when we went into COVID, we had to adapt quickly. We had to be rapidly, we had to adapt to data, we had to adapt to infrastructure. And we were lucky in South Africa that our infrastructure was just getting to that point where suddenly it became actually accessible. If you think we're having this conference 18 months ago with our infrastructure, we would have struggled to be having this type of infrastructure availability. So infrastructure came along at the right time. There was this rapid development, and then certain barriers were overcome quite quickly. And it was a case of willingness of people to adapt. So pre-COVID, we had the situation where there were regulations, and it was this lengthy process of trying to get things to work. When COVID came along, people had to adapt. And so what we found is like regulations changed quickly. For instance, prior to COVID in South Africa, it wasn't legal to do a video conferencing consultation. There was challenges with that, and doctors were, now what happens? Oh, no, now we can do it. It's easy. So those barriers dropped. And I think that left the opportunities for future development and future growth to flourish. And we're still there, and we need to nurture that. We still need to continue development of infrastructure. And one of the big things for me is we need to develop our skill sets, because that's going to be a key element. Thank you.
That's excellent points, Vikusi and Clive. You kind of touched broadly about how the corporates think, and also, you also proposed the layers of compliance, especially around the regulatory sides, and then how suddenly that has changed. And it has kind of been the story of COVID. Who are easy to change, or who are faster to change, have been on the board than the other countries, so which is an excellent point. And I would like the rest of the panel members to comment on the barriers that they might have seen. And probably the next the point of discussion in the panel goes around that, in terms of the barriers that you have encountered while you're implementing Industry 4.0, and how from your personal experiences have you faced it and challenged these barriers, and has there been a specific strategy around handling these barriers? So again, Clive and Vikusi have opted to this question, but I would like to open it up with Althea, and then we can move down to Clive and Vikusi.
Yes, sorry. Yes, so what I wanted to say is when COVID first hit, it was a very interesting experience, because I happened to step over from financial institutions in Europe into the UAE, into aviation, literally just 2 months before COVID hit. So what was very interesting for me coming from Europe and coming to the UAE is that particular semi-government organization had a very conservative view of work, like where do you work, which location you worked. While in Europe, it was never an issue. You could go and come, and it was very fluid. And I had that experience the first 2 months, and then COVID hit, so we all had to go home. But it was even on the way going home, there were top executives were really against it, with titles with digitalization in it. So it was, to my, let's say, it was quite unbelievable. So I can imagine many countries around the world that have that similar type of work pattern, that you must be physically in an office with your peers to be working, even though you're an adult and a responsible human being. I think, thank God for COVID, for that reason, that it made people, I would say it made the so-called burning platform disintegrate, as Clive was saying. There is no platform. People are just jumping around in the water. They have to be very real. So from that perspective, I think it was a good thing. It shook us awake. That's my
excellent point, Althea, because when COVID struck, almost everybody were stuck, and we were struggling to know what we're going to be doing next. And this was, in my opinion, long due. We were saying that we're going to be entering into the 21st century with a bang, with all computerized things, but we actually did not take the digitization efforts that we should have otherwise taken. And we needed a pandemic to force us to make that digitization change, to make us come on board with the Industry 4.0. And I'm sure all of us would agree on that. It only, like in retrospect, more than a year and a half, or close to a year and a half, we are seeing that not much has actually been impacted, even though we are not physically in offices. So that old model has been shook. So thanks for that, reconfirmation of the revelation that has come to all of us through COVID. Clive and Vikusi?
I think Sudesh,
Ben?
Perhaps I can throw in my weight on that topic.
Definitely.
And when we talk about pre-COVID and post-COVID, and sometimes we may easily look at the surface in terms of the consultancy, but I tend to look in the medium term, I tend to think that there's a lot that has changed in terms of diagnosis technology. We leverage technology in proper diagnosis. What we know as the feelings, or what we have been told, that if you feel like it is COVID, because this is gonna take quite making and in this post-COVID period.
Fantastic points, Benjamin. I think the time of elective surgeries or elective procedures have been moved because of COVID, and that is actually leading to critical care for people who need their attention the most, which is like say, for example, lifestyle disorders, or like diabetes, or even cancer for that case. The amount of treatment options that people get there, because they are vulnerable populations, so they don't want to get exposed, so they stay away from hospital, but indirectly they lose their health. So which is a kind of a complicated vicious cycle that we are getting caught into. One of the key points that you also raised, Benjamin, is about the fact that we need to capitalize on the existing technologies out there, especially now that we have so much of data. Isn't this an actual avenue for us to use the machine learning algorithms to educate us whether this is the right direction, whether this is COVID or not, or anything else? So let's hear from Vukuzi, and then we'll go to Clive to hear their thoughts on the topic.
Yep. Thanks, Sudesh. And I just wanted to come in more on the issue of data. And I mean, when you posed the question earlier, you asked around the barriers. So I do believe that, especially in the South African context, data does still remain to be a barrier, primarily because as much as we do have data, the extent to which we have liberated the sharing of data across enterprises has been very, very limited. And also, we have just not liberated the members or the customer or the individuals to be the custodian of their own data, for example. So what makes it sometimes very difficult is that we at MedScheme, we are sitting with data for the schemes that we administer, and we've got a fairly decent history of that. But the issue is that we've got very limited to no visibility of a granular level of similar data, say, that is sitting at the discovery side of things, and say momentum and so forth. So when people, for example, lift from one insurer to another, you kind of create this disconnect where your doctor does not necessarily have, is not as empowered in terms of being able to knit the dots historically to be able to enhance the quality of your diagnosis, as you correctly mentioned, in terms of applying things like machine learning to really move forward in the sector. So I do think that remains to be quite a bit of a barrier. And my view is that the solution really lies in really making the member or the customers really the custodians of the data themselves, and not so much the administrators or the insurers as it currently really is in reality.
Fantastic, because let's hear from Clive. And I see Dr. Wuma has joined, so we'll move to Dr. Wuma after Clive. Clive?
Yeah, thanks. I think Vukuzi puts in very, very valid point there. I think with one thing about data is only as good as the quality of the data you get. And I think we have maybe lots of data coming in, but the quality of that data can be problematic. And what COVID did is it ramped up. Everybody was just collecting data, but is that data really meaningful and useful? Well, we will find out a bit in the future. So one of the challenges has been that, yes, ownership of the data, and I think there'll be some discussion about that later. But for me, just in terms of implementation of this type of technology, I think what I like to just bring up is what I've seen from experience is, and this was actually pre-COVID as well, is that if you're wanting to have a successful solution or a successful project or a successful implementation of this technology, the first thing is ownership of the solution or ownership of the project. What I found in the past is that often you have a solution that's developed or a thing, and then the client expects the person who's developing that solution to do everything. At the end of the day, the client who's actually requiring that solution and requires it should take ownership. What we've seen in COVID as well is that in the past in medical's been quite slow to move with technology. If you think of the banking system and all that, they were very, very rapid, and you use a banking app to do your banking. And when you come into the medical thing, things tend to slow down. The users are a bit more precise than maybe, I don't know what the reasons are, but they slow down a bit. So, we get to the question of, with COVID, we had this rapid development, and adjusting to that was quite something that the medical team, medical fraternity, and medical developers of software had to adapt to. And we have a component of two sort of things. But ownership, project management is an important part of deploying your technology correctly. Often we find that it's the client that ends up, or the user becomes project manager, and it's not a great role for them to play. Support of the solution as well. We see a lot of pilots go out and pilot solutions go out, and then they're great, and it's nice, and then it just collapses because there's no forethought about how do we provide support for the solution. And I think the big discussion about industrial revolution is, what about jobs? So yes, jobs will change, but jobs are still going to be there because these things need to be supported, and they need to be, and medical comes with its own criteria, let me tell you that. So I think that those are important facts, but I'll leave back for the panel to continue discussion.
Awesome, Clive. I think both of you touched on some very important points because he highlighted the importance of continuity of data and bringing in the ownership back to the people from whom the data is collected. And Clive, you mentioned very rightly that healthcare has been very slow to adapt to these technologies. And it may also go back to how we train our healthcare professionals. We are training healthcare professionals in a very, very traditional, probably 100-year-old methodology. So probably, is there a room for actually innovating in that space so that the new generation healthcare doctors or healthcare workers are actually trained with more computers, with more software-based, with more interventions that are more digital before we can move into the era of digital health? Clive, any thoughts on that?
Yeah, just one thought. You talked about the training component, and I think that there's a significant gap and barrier to training of not just the doctors themselves in the terms of the technology, but also those people that support, health informatics as a subject as a whole, just general training and education with these new technologies. And in South Africa, I think we're really lacking behind in that. You can develop a developer, but that's one person in a piece of a puzzle that fits in a whole lot of different pieces. So there's lots of different opportunities, but one thing has to happen is we have to get our training components and our educational areas sorted so that we are bringing people into this environment that are ready to deal with it. And so that's one point I'd just like to raise.
Thank you, Clive. Althea, if it is a quick comment, because we need to move.
Yes, really quickly. We had the same point in one of the last sessions, that the overwhelmed workers with all the technology. What if we all decided, wait a second, guys, data is the system. Data is perpetual. And to train people on data is a lot more affordable and a lot more long lasting. Technologies will come and go. So if we take that attitude, I think that we would get a lot more cost efficiency and a lot more value for our health. Okay, that's it.
I can't agree more with you on that, Althea. I think we might need a panel just on that point that you have raised. But
yes.
So let me, without further ado, let's invite Dr. Vuma. I think we are talking about many, countrywide implementation and of, technologies like digital health technologies. And no one better than the director of e-health from one of the departments of health from UKZN, Dr. Vuma Makunga. Can you briefly introduce yourself and explain, tell us a little bit of what you do in the Industry 4.0 and the adaptation of digital health or digitization in health. Dr. Vuma, whenever you're ready. I think we may have a audio-visual connectivity issue here, but I'm just going back to Althea and Clive. I'll come back to you, Vukusi, because of the points that both of you raised in terms of initiatives that get started but doesn't get continued. Healthcare workers getting overwhelmed, but who are not actually trained. Is there a component that actually integrates these two, which relates to the sustainability of these initiatives that is actually lacking in the current stage? Clive, followed by Althea.
Yeah, so I have this sort of conceptual idea of what I call perceived value. And to bridge the gap, the user of the data, the user of a solution, the user has to perceive value in it for it to be adopted. The moment you get somebody that perceives value in a solution or a technology or a data, then they will start to adopt it. And so to bridge that gap. So if your users don't perceive the value of what they're doing, then you're not going to get good data. You're not going to get acceptability. But if they accept, so what you need to do is you need to bridge the gap by showing them the value. And because you mentioned about bringing the data back to the actual custodian, the patient. So when a patient perceives the value of using an app to collect data and can see that and can see the benefit, then I believe we'll bridge this gap quicker. But if you, and what are the criteria of perceived value? What creates perceived value? One, your user experience. If you think of the apps that you use on your phone, which ones are the ones that you use the most? The ones that are easy to use, that you gain the value from. And we have to apply, I think we should apply the same methodology when we develop solutions and technologies. If you see value, and like diagnosis you're talking with, if a doctor perceives that the diagnosis is helping him, he will use the technology. If he doesn't, he will not use it. That's what I've seen from experience.
Fantastic, Clive. You kind of touched a lot of points, but let us hear quickly from Vukusi and Benjamin. We've got two other important burning questions to address in the panel, but Vukusi and Benjamin.
Thanks. So I think Althea hit the nail on its head. I think one of the things that you obviously hear being mentioned a lot is that digital is not technology. It's all about a complete change of the business model itself. And I think we need to consider the multifaceted nature of what it means to successfully implement digital transformation from an organizational perspective, especially, and look at all the components of the process, the people, the technology, the data itself, the governance, driving the right culture. And I think once we kind of have a very good understanding of all those components and kind of like understand how each of them need to play a role in moving us forward to where we want to be, we then start investing rightly, even from a skills perspective, but also in how we enhance our processes, and not just the technology and the tools, because she correctly pointed out tools will come and go, but if you anchor people in the right frame of thinking and business model, then that becomes more sustainable, and you're able to iterate and move in an agile way as this thing continues to evolve, because it's evolving so fast, and none of us can probably even project beyond 5 years, to be quite frank here. So I think that's one of the key things to keep in mind.
Dr. Vukusi has been quite optimistic in saying 5 years for data. I think that's going to be quite a long time when it comes to the timeline of data. So let's hear from Benjamin.
Thank you. Yeah, that's a good point from Vukusi. And one that captured is that we need to really understand that this just not a technology issue, but it's an issue of change in the business model. And one important thing that needs to be understood is that the way medical science is being approached in this age is really different. And this ought to really be understood from the point of training. At the point of training, a medical scientist or a doctor, a practitioner should be able to understand how to interact with the data. And especially because when you're using AI or other medical technologies, robotics, these technologies all rely on, on a number of data oracles that feed it with data, like wearable devices. I mean, when it comes to diagnosis or following up the patients. One thing that happened in Kenya, in a national hospital in 2018, that was tragic, was that surgery was done on a wrong patient, and this was a surgery done on a wrong patient, confusion of patients in a national hospital. So I think such small mistakes are an issue of data and an issue of the quality of data, and even the practitioners themselves understanding how to collect data and quality data for that matter, and even how to process that data. Then further, one thing that also has to be looked at is the regulatory aspect of it, because it's been interesting that most jurisdictions now are really just copy pasting the GDPR and not really looking at the specificity in terms of our own jurisdictions. How do we collect data? How mature are our systems in collecting data? And how far can we process this data? Because in Kenya, recently we have the Data Protection Act, and during the period of reviewing this Data Protection Act at the bill stage, we had really a long tussle with the ministry of trying to really also advise the ministry on certain aspects of the regulation. Because if, for instance, you make it difficult to reprocess data, then medical research and even the use of this quality data that has been collected becomes difficult. So from the point of data collection to the point of data processing, despite there being protection of personal data, there has to be really, really usable, or rather very smooth and friendly regulatory to make it possible really to use this data. Thank you.
Thank you so much, Benjamin, for this. So I see Dr. Wuma is trying to join. When we are able to hear him and see him, we will let him talk. But Althea, I would like to pose the next question to you, and I'll get the rest of the panel also to respond to it. That is basically dealing with the experiences in data management and the legal requirements in with data management, especially around the newer implementation of personal information protection acts, and that varies from country to country and region to region. So with your experiences in handling data, which predominantly all that we're talking about is personal information, are there any legal requirements, experiences in legal requirements that the panel should talk about, and the audience can be educated upon? So you can address this question as well as go further on Benjamin's point. Thank you, Althea.
Yes, so I will start actually with the general answer on data management in terms of experience on data management. So I would say we're probably now in the fourth iteration of data managers. I'm talking about data leaders who are managing multidisciplinary data teams. So data teams that have data modelers, data engineers, data scientists, generalist consultants, people who are working more with the business side, data governance people. There's a whole slew of data professionals. So I find it always fascinating how people kind of skirt over all the different facets, architects, everybody. that's working on data. It is a full-fledged discipline. It might be a young one, but it is full-fledged. So there's a lot in there. And I'm just pulling on the two comments from Benjamin and Vukosi, I believe. We're talking about the pipeline to get to an AI model as an example. That's just one, place you want to get data to. There are huge stumbling blocks along the way. One of them is having, the right type of dream team to work together. A lot of people think, oh, I'll just get 10 data scientists and, they'll figure out the day. It doesn't work that way. Usually you need a 5-to-1 ratio of data engineers to data scientists. But I mean, there are other people involved in that process. And if I think about to make it successful, I mean, to get an end result. So if I think about what Benjamin, I believe, was speaking about, that the data is as good as it's trustworthy, we all know that if we don't get good testing data to those algorithms, for example, you're done before you started. Most companies can't even dream about having multiple models developed and running simultaneously to create a real laboratory. Yeah, why? Because along the pipeline, especially in the beginning, where people have to think about what they want to achieve, get a business case around it, translate that into a business information model, into data sets. Oh yeah, we don't actually have these data sets. It's all of that. And then you still have to do the preparation. So my point is, a long-winded answer, but I'm taking my time because the guys did too. Data management is really a full-fledged sport. There's much more expertise that needs to be built into the practitioners that work independently and together. We need to get data to talk to us instead of just being like a bit and a byte. And we need to contextualize it. And I think if we shift in that direction, just globally, then we'll be in a better place for every application of data. And the point about specifically the legal aspects of GDPR or any of the other compliances around the world, I would agree. I believe Benjamin mentioned it. Many companies just have, or countries have copied, the law from Europe, which is not probably the best thing to do because you need to take it in context to your own sovereign environment. I had the pleasure of dealing with the Philippines copying GDPR for the Philippines, which was not fun. So my point is, yes, we need to be very mindful. It is a law, so it is prosecutable. There's big implications, and it's not about, it's just thinking about, you need to have a purpose to have access to this data and handle it. And if you don't have a purpose, you shouldn't be, handling it. And not all data falls into that category. But my advice is to take a value stream approach to it. And the value stream could be beyond your brick and mortar, meaning your actual organization, into your partners, because you've allocated a lot of responsibility out to your partners. So the whole value chain needs to be looked at, and things like consent and I'm trying to think, privacy by design, these kinds of things, they can be manageable, but unfortunately, most organizations are pretty immature when it comes to data management. So then putting a law on top of it just kind of, threw them into, the last level of university when they haven't even finished at A levels. So it's that kind of situation. And I hope that's been helpful so people can reflect on it.
That's fantastic, Althea. I think you kind of answered on behalf of the entire panel. I think it kind of going from the Philippine experience to the European Union experience to the African experience to the Middle Eastern experience. That's quite well-rounded. Thank you so much for that. Vukosi, is that a legacy hand, or do you still?
Yeah, I just wanted to add a bit on what Althea has mentioned. So, I'm from a data background as well. So if you really look at, for example, the Dharma wheel, which is really our Bible arguably, and you look at all those 13 areas from architecture to quality to metadata, storage and operation, security, governance, business intelligence, master and reference data. She really makes a very valid point to say there are so many touch points And if you don't have a very good understanding of your value chain or data strategy and understand what each touch points and what each of those skills mean to your value chain, then you won't be able to just overlay a law, a policy into making sure that actually you really fully do comply. And over and above that, for me, the biggest test is how are you able to successfully embed POPIA and your data policies into your operations, especially from a technology and business processes. And if you can't do that, then you just really have this document that is shared, gathering dust. I don't mean physically somewhere, but actually the reality is not a match to what you claim to have in place. And it speaks to what we even saw in South Africa a week ago, where everyone was just spammed with emails of everyone just trying to do it for the sake of complying. But actually, for me, the issue of consent is all about gaining trust with your customers. So it's all about making them understand that you want to adapt and say, me work. Go if you get the right culture where people understand that treat data the way they would treat it if it was their own data. So I always ask the question, if we still do that, so it's beyond the policies, embedding the right culture and making sure that your business processes also come alongside how you implement this in a way that best fit your purpose of the organization.
Thank you, Vikusi. I think, I was having a little bit of trouble hearing the later part of your conversation, but, the reason why I was smiling so broadly was the fact that, ever since South Africa started implementing the POPIA Act, what was really annoying is the number of emails that we were getting on a daily basis from various service providers saying that we are POPIA compliant. For me, so what? Why do I get 10 different emails every single day saying that you're POPIA compliant? That actually is interruption into my personal space or my personal communication space. So I found that quite a thing to overcome. So Clive, I hope you also had hundreds of emails around POPIA, but maybe your experiences on that.
No, well, my experience has been actually quite good because there was an opportunity for me to unsubscribe to all those unnecessary ones. So I went down and went, no, I don't know you. Unsubscribe, I don't know you. Whether that's actually going to have any effect, I don't know. Yeah, this whole thing of suddenly everybody woke up, and then there's this flurry. It happened with GDRP as well. And yet, we only actually, there was an extension to the actual papaya coming into, it's only in February. But yeah, so the point is, will everybody sit and just wait? And then in February we have the same problem. And because he has very, very good concepts about that, it's not just about looking at a piece of document and then trying to fit into it. You actually have to understand the process. And for me, the regulations are there we need to share information, but we need to share it appropriately. And what do we have to do to make sure that happens? So that's it.
Fantastic, Clive. I think you taught us one thing more than other digital things, fourth industrial revolution that we spoke the whole day. The most important thing is I'm going to look up all my POPIA emails and then unsubscribe to the ones that I don't need them. So thank you so much for that education. But, I want to, kind of go with a little more serious question to the panel. We are dealing with Industry 4.0 and the fourth industrial revolution. There is also a concern with the laymen about the job losses that it can cause. And there is we had this kind of apprehension when computerization or digitization started, and a lot of people actually opposed from moving from paper records to digital records because they feared that they will lose their jobs. And now the similar kind of fear is stuck with a lot of people. If you ask like lay people, most of them are concerned about losing their jobs more than the number of opportunities that Industry 4.0 is going to create in the new avenues. There is a fear for the fundamental or bottom of the pyramid people that they are going to lose more jobs. And I would like to know, the panel's expert opinion on this in terms of, whether is that really the case? We all know that there is light at the end of the tunnel. There is definitely more opportunities on the other side, but the panel also highlighted the fact for the need for changing the skill or upskilling requirements and changing the upskilling requirements in a different dimension. So how is that, in your opinion, going to be translated to the last people on the streets? How will that change? And do you really see an opportunity for the people in the bottom of the pyramid to benefit from the Industry 4.0 and more from an economic and social justice point of view? Anyone?
Oh, sorry. Go ahead, Dr. Huma.
Are you available?
Yes, I'm available. Thank you so much.
Thank you so much for joining us. Do you want to address to the questions that we raised?
Apologies, I had some glitches. One of the biggest fear related to the new technologies is that the robots and the artificial intelligence will replace the human factor in work, leading to the technological unemployment. This is not the first time that people face their technical process as a threat to their jobs. If you remember that in the 19th and the 20th centuries, when another major wave of technology progress took place, similar fear had risen, but they had not been proven right, because technological achievement of these countries finally drove to the creation of the new jobs that had fully compensated the consequences of the jobs saving technology adoption. However, in the view of the fourth industrial revolution that began in Europe and in the US and in the USA, the fear that the automation and digitalization will drive to the end of work wakes up again. A great discussion about the possibility of human factor replacement by machines and robots, and a probable creative disaster have emerged in the series of studies. If I can mention just maybe few, the one was conducted by Frey and Osborne. The study supports that 47% of jobs in the United States may be at risk of automation in the near future. On the other hand, the Bowles conducted another study which concluded that the proportion of sensitive in automation jobs in Europe varies from 45% to 60%, with Southern Europe being more exposed to a possible automation wave. The discussion about the consequence of the Industry 4.0 in the World Economic Forum in Davos in 2016 concluded that about 70 million jobs are at risk in the next 5 years, with women being more affected. But also, the low degree of adaptation to automation may be the most important among the risk factors of exposure to automation. And countries must acquire the mechanism to help their citizens to be quickly and easily adapted to the new reality. In technologically advanced countries such as Japan, South Korea, and Singapore, men are increasingly working with robots in order to be highly adapted to automation, reducing in this way the unemployment risk in comparison to other countries where adaptation to automation is slower. So I don't really think that automation will really take jobs of human. And what needs to happen is that people need to be skilled, capacitated in the machines. For instance, those who have lower education must also be exposed to those machines, and together with those who are in the mid level of education, because those who are in higher, they already exposed. They are already exposed. They are not really affected by technology. I'll stop there.
Thank you very much, Dr. Buma. Yeah, you kind of started addressing question 3. We have a few questions from the audience, and one is about the fear of losing jobs and how artificial intelligence is going to be beneficial or causing a job loss trigger. But let's hear from the rest of the panel. The order is Althea, Benjamin, followed by Vikosi. And you can also feel free to respond to the questions on the chat.
Sure. Yes. Okay. Well, first of all, I think we do all, because we're all in a very privileged position on this panel. I do think we all need to take a moment to have compassion for people who fear and are not aware of, the potential opportunities that this massive change in everything we know and everything we do is going to bring towards us. So I would like to kind of follow on from one of the last points that Dr. Zuma just mentioned, and it had to do with financial inequities. In my profession, data, that's actually a place where a lot of people who have, if they have skill, if they don't have skill, if they have, let's say, non-technical skills, hybrid skills, and technical skills, there's a place for them to gravitate to. So actually, some of the data for good work that we do is to introduce data to different parts of the population, including women, of course, to give them financial equity, because if they can speak the language of data, they have a place in the future. That's one particular professional area that could go across many different areas. But I would also like to say, taking a step back out of my profession, looking at the world as we know it, there are many things that the world is not managing well. Whether or not you agree or disagree, there's a whole industry that's going to spring up because of all the climate challenges, environmental, ecological challenges the world has. And it has that knock-on effect for so many other areas. So again, it's not about the level of education that you have or different people have. I think it's actually an issue, a crisis of leadership, meaning people who are in leadership positions to dare to possibly change the mode of business models and to bring people in instead of massively firing people to retrain people or bring in people that they maybe never would have thought of bringing in the old paradigm. So actually, I think the biggest challenge is not artificial intelligence. I think it's the mindset of humans. And if we can get over ourselves, I think, the future is really bright. I know I'm a person who is all about the glass is half full, but that being said, there are so many things that are not being managed that we could create new jobs and shift people into that instead of perpetuating the panic. And I feel we need to get more back to the facts and work together to move the whole, world economy forward. There's a lot of work to do.
Thank you, Althea. Benjamin and Bukosi, we are going to be very short of time. So if you can keep your responses short, then we can do a final round of conclusions.
Thank you, Sudesh. Yeah, just maybe taking it up from what Atyas have mentioned, the role of people in leadership. I think it's really time for us to really stop crying foul about technology or emerging tech, maybe bringing up causing unemployment. It's time for us to really take up, and this includes, of course, people in leadership in government, especially roles that are in line with technology, data. These are people that can really help in influencing, advising the government to make the right decisions, particularly in ensuring that there is upskilling in different sectors. There is upskilling of employees, government employees in healthcare and in the other sectors, because there's a lot of work to be done. But I think that the training really needs to factor in the fact that the global workplace is really changing. Therefore, the training also has to change. Yeah, it's a fundamental thing that has to be integrated in every training and every syllabus, every curriculum. This thing has to be integrated for us to really have a long-term change.
Fantastic, Benjamin. So no longer Industry 4.0 can be in isolation. It needs to be embedded in every department of life. So that's a great point. Lucy.
Thanks, Suresh. I'll be quick. So I think Dr. Vuma touched on a bit of this to say from one industrial revolution to another, what has been quite clear is that we have ended up with more jobs. So, and Althea also mentioned that it's brighter on the other side, but it's more about how you take people alongside that journey with you. And I mean, borrowing a bit as well from literature around these AI technologies in terms of the types of AI, I'll touch primarily on the one which speaks to the narrow AI, general AI, and the strong AI. If you really look at most of the AI that we are seeing in almost all the industries currently, it really speaks to arguably weak AI, where these machines or these computers do one thing very well. So I think that gives us an opportunity to have a very good understanding in terms of which jobs generally are so mundane that they are one-dimensional, that AI will take over. And secondly, in the 90s, we're talking about whether companies are going to be technology companies, use of computer. I don't think we're having that debate now. You may not be an IT company, but everyone uses IT. That's why we're having this meeting. Everyone has a laptop, everyone has an iPad, everyone has a cell phone. So I think if we approach the issue of digital skills and data skills that way, to say we are going to eventually get to that world where everyone know how to use these things at a basic level, just like we went through the same phase with computers, then people are going to start evolving with this into a new way of working and the new skills and jobs of the future. And as a result, we should not fear the loss of jobs as we currently do. So I think that's my 2 cents worth.
Fantastic. So we are in the last couple of minutes of the panel, and we have got a few questions about how to introduce technologies and these to recourse crunch countries and to how do we avoid malpractice of data sharing. I would like to invite the panelists to briefly, very briefly, do your closing remarks and if possible, address these questions. Maybe let's start with Dr. Vuma and then we'll go around the table, around the screen. So, Dr. Vuma?
Thanks very much. It's been grateful that we had this session. I really appreciate it, and it's also eye-opening not only to me or us as a panel, but to the world as a whole. Like, look, the 4 areas that we've touched on are also very critical. When you look at each and every situation in our work environment in our countries, we see that we're still far from achieving what we plan to achieve, more so in terms of implementing our policies and taking advantage of COVID-19 at our workplace. Thank you very much.
Thank you, Dr. Vuma. The order would be Benjamin, Clive, Vukosi, finally Althea.
Thank you, Sudesh. Yeah, my closing remarks is that I think we've really covered much with regard to data, and I think let's make this conversation really a part of every event, or rather every program that entails, whether it's medical science, whether every industry we talk about, let data, let the emerging technology and how we can integrate all these things be part of our conversations. And now with regard to how we can introduce this to recourse crunch countries, I think it all boils down to leadership, because these are countries that are really for some reasons the leadership is broken, and that has for some reasons also result to broken systems. I think there's really a lot that should be done by the leaders in those countries, and also by the leaders in other countries that probably are these countries rely on for support. There's need for probably technology aid rather than just focusing on financial aid. There's need for technology aid and really exchange with regard to skilled personnel and all that. Thank you.
Thank you. Clive?
Yeah, thanks. Just in closing, I'm sorry, I think answering some of those questions on the panel might take a bit longer than that. So I just would rather just conclude. In terms of the technologies, I think what these technologies should be doing is enhancing humanity and improving, assisting humanity. I think where technologies will be removing humanity, we need to be asking ourselves, why would we be introducing those technologies? So I see the fourth industrial revolution and within health, if we can assist people to do their jobs better, with better accuracy, and get better outcomes, then we're on the right path. If we start to use technologies that interrupt that process and might be financially only considered, I think we need to be sitting back and saying, are those really, is that the path we want to follow? But that's my personal opinion.
Fantastic. Thank you, Clive. Bukusi?
Well, thanks, Adesh. And I think Clive hit the nail on its head there. I think it speaks to the issue around how we do this ethically as businesses, as the entire stakeholder community, even from a public and regulatory perspective, to ensure that we are using these technologies and this data to enhance the quality of life for our people, regardless of which sector you are in. And in healthcare, if these technologies are helping us improve access to quality healthcare and improve the healthcare outcomes themselves, for example, then that's what the focus around why we're doing this should be about, and not so much be fixated as to we are automating so that we can be more efficient and reduce jobs and increase profits. So I think we need to be to create leaders that are more ethical and that are able to communicate a greater vision of what the possibilities of AI and these other related technologies could be.
Fantastic.
Thank you. Thank you, Suresh.
Althea, your final remarks.
Yes, so 2 points. I want to answer question 2, but I also wanted to say on this general topic, I think data leadership and executive leadership overall, we need to really embrace that, things like new disciplines that need to be brought into the mainstream need to be truly embraced by putting their money where their mouth is and putting the spotlight to champion specific causes. I mean, data management compared to technology is a walk in the park. I mean, in terms of the budget. The budgets are not as exhaustive. So I think that's something that if we change our mindset, we can quickly get caught up. The other thing is question 2 talks about how do we really deal with unstructured data and get these large volumes managed and protected away from theft. It's a multifaceted question, but I think we need to go to non-conventional data management practices where we use things like semantic architectures and contextualized data, so rich link data in things like knowledge graphs, because they're much more powerful and they speak a language to us that we understand instead of being bits and bytes. And that would be my answer for the question number 2. Thank you.
Thank you so much, Althea. So we have had an excellent discussion on Industry 4.0 and its implication on digital health. And we discussed about multiple streams of things, like going all the way from educating the population to implementing and making a sustainable solution. I think the panel was very educative, at least for me, and I'm sure it is for the rest of the audience as well. And it's time up, so let me hand it over to Sneha, and let me thank the panelists for their excellent contributions. Thank you, everyone.
Thank you.
Thank you, Suresh. Thank you, everyone.
Thank you very much, Sudesh. Thank you, everybody. Have a lovely day.
Thank you.
Thank you so much. Thank you so much, dear panel members, and thank you so much to Sudesh for beautifully conducting this panel. And now that we are at the end of the event of day one, I now move to Dr. Rajiv to give the closing remark as the chairperson. Thank you.
Good afternoon, ladies and gentlemen. Let me start off with what Althea mentioned. Data is the new soil, not oil. I think it's a very good analogy you have explained. Thank you very much, Althea, for that. I've learned quite a bit. I'm sure the participants have learned as well. A lot of new initiatives, a lot of initiatives that are happening all over the continent, and there should be a place for all this to converge and maybe use it to the better advantage of the continent. It's really important to upgrade our healthcare system in healthcare to provide better patient care. The digital divide has to be how do I put it, has to be sorted as soon as possible, especially in the last mile where connectivity is still an issue. So we have to look at providing access of care to our health workers. During COVID, we have seen a lot of misleading information that has been shared on the social media. So that is leading to something called as an infodemic. An infodemic is an overabundance of information, good or bad, that makes it difficult for people to make decisions for their health. Misinformation, disinformation, and fake news can cause real harm to health, public trust, social cohesion, and emergency response. So we have to make sure that that the information is accurate to prevent social unrest. Like when the COVID lockdowns were being planned, people went on a rampage. I mean, they went out and started buying and stocking things. So it's accurate. It's important to have accurate information that needs to be passed on to the community. With limited infrastructure, one had to understand which technology makes sense to have. So we are very limited when it comes to adoption of digital platforms. So what is important, as was mentioned by one of the presenters, was to have a pan-African telemedicine network, and we should look at having a unique identifier for the whole continent, not just a country. South Africa has embarked on it. We have something called the health patient registration system that offers a number, the health patient registration number, to every patient who walks into our facilities. So that is important. And some other things which I picked up was that we have to look at population management using clinical decision support. And what came out very clearly was to use a screening tool in the community, especially for mental health, and training of health information managers that can actually help us quite a bit. Data is really important in making good clinical decisions. It's important to maintain the quality of the data, and the ownership of data is also very important. Implementation rules of these upcoming technologies are important. New generation health workers should be trained with more options with these technologies, especially when they are training. They should be trained on health informatics and telemedicine, and that might actually assist in bridging the digital divide. When I think the last panel, when they spoke about the jobs being lost, but you know, in the new era now, without IT skills, you can't even get a job. So you have to get onto IT and learn IT, and then if one job gets lost, there are 10 innovative avenues or disciplines that might open up, especially in data leadership. And this is the new norm now. So I think it's important that we need to look at data and information management as the new way of handling things. So I think I'd like to stop there. Thank you, Sneha, for thanks the panelists and the expert speakers. They have to come up with very what do you call it? How do I put it? Thought-provoking presentations, and we hope that we'll see you tomorrow again, and then we'll learn some more tomorrow. Thank you, Sneha, for the.
Thank you so much, Dr. Rajiv, for such an interesting closing of the panel. And you actually have summarized the whole session of today's. And now I'm pretty sure our audience must have had some great takeaways from here. And thank you all to be present here, and hope to see you tomorrow again for an interesting conference again. Thank you so much and have a pleasant evening. Thank you. Good evening to all.